Hi, good evening. Hi, good evening. Is Dr. Sabha there? Join.
Recording.
Hi, good evening. Dr. Rahul from SGPGI. Am I audible?
Yes, sir. Yes, sir. You are audible.
So,
Sir,
when are we starting?
sir, you can continue, sir. Sabha, sir, will join soon, sir.
So, have the participants joined? Because I can't see many people here.
Yes, sir. We can wait for 5 minutes.
So, let's wait for 5 minutes. We'll then
Yes, sir.
continue after that. Okay.
Right.
18 मिनट है ना
So, on है, on.
ऑन है ठीक है ये कैमरा ठीक है लास्ट वन तुम कोई रिपोर्टर नहीं जाओ अभी शुरू कर देते गुड इवनिंग एवरीवन like today we will be starting the day 5 of ASRICon and to start with we have Dr. Rahul, who is an additional professor at gastrosurgery at SGPGI and his team. So being the main rapporteur, Dr. Rahul will introduce his team first, then what all they will talk, and then we will over to you, Dr. Rahul, and thanks a lot and lot of this one from all the office bearers of ASRI for this wonderful gesture to teach rural surgeons and students who will be linked in through YouTube. Thank you.
Thank you so much, sir, for the opportunity. And we are more than happy to share our views on various GI procedures. And it will be a combination of open and laparoscopic techniques. And we'll be sticking to the basics. So we have five consultants from our department. We'll start with Dr. Prashant, who will be talking on laparoscopic colsectomy, safe method, and bailout procedures, followed by Dr. Yash on right hemicolectomy. Then we'll have Dr. Sarangi, who will be talking on laparoscopic CBD exploration. Then we'll have Dr. Payal, who will be talking on hydrolysis, management of hydrolysis in liver. And finally, we'll have Dr. Kush, who will be talking on splenectomy. So we'll start with Dr. Prashant first. The questions are most welcome. Whosoever has any query can write in the chat box. I'll try to manage. I'll try to answer those questions through our participants or through our team or myself. I myself will answer those questions, and uh, we'll try to stick to the time provided to us. So let's start. All the best to everybody, and we'll start with Dr. Prashant, who will be sharing his views on how to do a safe cholecystectomy, laparoscopic cholecystectomy, and what are the bailout procedures in difficulties. So over to you, Dr. Prashant. So Prashant, unmute yourself, please. Dr. Prashant is assistant professor in surgical gastroenterology and he has joined recently. He's a prolific surgeon and he does very good laparoscopic surgeries. So he'll be talking on laparoscopic cholecystectomy. Dr. Prashant, are you there? So he'll be joining soon. Probably there is some technical issues. He's not sitting with me. Other people are with me. So he was there. He
You
must
can
be.
start. You can interchange also, boss. No problem.
So if so, we can start with Dr. Yajnadat Sarangi. Then he will be talking on laparoscopic CBD exploration. If by the time Prashant will join us. So over to you, Dr. Sarangi. Please continue.
Am I audible, sir?
Yes.
Yes, please.
Sir, can everybody see my screen?
Yes, boss. Your screen is visible. You are
Can
audible. Very
everybody
much audible.
see my screen, sir?
Yes, continue.
Okay. Good evening, everyone. Now I will explain about common bile duct exploration and current indication and techniques. First introduction. Gallstone disease is the second most common primary admission diagnosis all over the world, and in GI, hepatobiliary, and pancreatic disorder, and concomitant choledocholitis occurs in 10 to 20% of the patient under surgery for cholelithiasis. And there are multiple management strategies for CBD stone. There are endoscopic therapy, there are laparoscopic surgery, there are open surgery, and there is rapid advancement in endoscopic techniques, and there is increased use of laparoscopic CBD exploration in recent years. So, choledocholitis means stones in the CBD can be two types: primary CBD stones and secondary CBD stones. Primary stones are mostly those formed de novo in the bile ducts and associated with biliary stasis, infections, strictures, etc. And secondary CBD stones are mostly they slip out from gallbladder and migrate into CBD. And this is the most common CBD stone, who is secondary CBD stone, accounting for 80 to 90% of the CBD stone. How choledocholitis patient present to us? They mostly presented with intermittent and colic pain in the right hypochondrium or epigastrium, and they also present with intermittent jaundice, with there are icteric, yellowish discoloration urine, dark color stool, dark color urine, and also associated and sometimes pruritus. They also can be land up in severe complication like severe cholangitis, which include fever, chills, and alter mental sensorium, which is known as Reynolds pentad or charcoal striate. And they also can land up in severe pancreatitis also. And many patients require ICU stay, hospital stay, ICU admission for severe hypotension and fever and severe sepsis. So CBD stone is a very alarming. Stones with CBD stones with cholangitis is a alarming disease with severe severe condition. Then how will you evaluate this CBD stone? Patient presented with those symptoms of choledocholitis. How will we evaluate this patient? So according to ASG guidelines, American Society of Gastroenterology guidelines, this patient can be divided into three groups: high risk for having a CBD stone, there is intermediate risk of CBD stone, and low risk of CBD stone. High risk means that the patient can be presented with symptoms of cholangitis like jaundice, fever, and hypotension, and pain abdomen. And also serum bilirubin more than 4 and with the dilated CBD, or the documented stone in CBD in the USG or any cross-sectional imaging. These are high risk patients of choledocholitis. Intermediate risk are those patients where there is some amount of doubt that is there a CBD stone or not. So the criteria for intermediate risk are diameter more than 6 mm with cholecystectomy, or diameter more than 8 mm without cholecystectomy, or in abnormal LFT like raised alkaline phosphate, raised GGT, or age more than 55 years with a presence of gallbladder. These are intermediate risks. So, and low risk, there is no other factor is a low risk patient. Then how will you evaluate this? So first, if there is any high risk factor, ASG guidelines recommended directly go for ERCP, endoscopic retrograde cholangiopancreatography. So any high risk factor, like there is a documented USG stone in USG, CBD stone in USG, so we can directly go for ERCP, and if possible. And if there is any intermediate risk factor, we'll go for any urgent imaging like MRCP, US, and intraoperative intra-ultrasound. We'll discuss later. But practically speaking, no endoscopist or no surgeon will go for ERCP or any surgery for CBD stone without undergoing MRCP until otherwise patient in severe sepsis or severe cholangitis. So that's the indication. So we could first directly go for ERCP and stenting, endoscopy, retrograde cholangiography, and stent placement if there is a cholangitis. Otherwise, practically whenever there is a doubt of CBD stone, like dilated CBD with a gallbladder, or any raised alkaline phosphate, raised gamma glutyl transferase GGT, or raised bilirubin with dilated CBD, we should always go for MRCP first to document the CBD stone. Then we'll go for any invasive procedure, whether it is a ERCP or it is a or CBD laparoscopic CBD exploration or open CBD exploration. So practically, we always go for MRCP before any invasive procedure to confirm CBD stone. So what are the management options if when there is a CBD stone? There are multiple approaches, like endoscopic approach, in ERCP, percutaneous approach by PTC, or by minimally invasive laparoscopic surgery or classical open surgery. So all the management option depends on patient factors and the clinical expertise availability or judgment of the clinical judgment or any evidence for the clinical trial. So now I'll explain an algorithm for management of CBD stone. If patient present with symptomatic cholelithiasis, or there is a cholangitis, jaundice, or anything, so how will we go for this patient? If patient is severe cholangitis and in sepsis, shock, and the documented dilated CBD or CBD stone, we should go. If patient is severe cholangitis, we can go for direct ERCP. Followed by, if successful ERCP, then we go for an interval laparoscopic cholecystectomy. If there is any suspected CBD presence of CBD stone, like bilirubin more than 30, dilated CBD, or there is pain with dilated CBD, then we should always go for a urgent imaging like MRCP, or then followed by, if there is a stone present, we can go for ERCP followed by laparoscopic cholecystectomy, which we usually follow in our clinical practice. If there is a CBD laparoscopic cholecystectomy with cholelithiasis we will go for a ERCP followed by CBD clearance. Then laparoscopic cholecystectomy. If ERCP failed, then we can go for a laparoscopic cholecystectomy with laparoscopic CBD exploration or open CBD exploration. Practically nowadays, usually we go for ERCP first for CBD clearance, then we go for a laparoscopic cholecystectomy. So and if there is no but always go for any, always before, I'm repeating again, always going before any invasive procedure like ERCP or CBD exploration, we should always do a MRCP. And also endoscopic ultrasound has a definitive role in the is the most specific imaging modalities for CBD stone. When there is doubtful stones in the CBD, and MRCP could not pick it, or any very little sludges, or any sludge or very minimal sand like sludges, means in sand like structure in CBD, sometimes MRCP failed to pick up that, then US can be a definitive diagnostic method for that CBD sludges. So either you go for MRCP, or available go for US before ERCP or CBD exploration. So at this current, in our current practice, we usually go for ERCP first, then followed by laparoscopic cholecystectomy. But what are not, so what are the indication of CBD exploration, laparoscopic or open approach at current practice, or in our current practice? The most common indication for CBD exploration in current days, in recent past, are when ERCP is not available, or ERCP contraindicated, or ERCP failed to clear the CBD stone. Then we go for a laparoscopic CBD exploration, laparoscopy or open CBD exploration. Then what are the other indication? Like there is suspicion of CBD stone, and in intra by any adjunct like US intra ultrasound or any cholangiography, you found a CBD stone. If expertise is available, you can go for a laparoscopic cholecystectomy, simultaneously laparoscopic CBD exploration. Then if your expertise available, then we can go for a single step lap cholecystectomy with CBD exploration without prior ERCP. And if they alter surgical anatomy, like there in post gastrectomy patient, there is no gastroduodenal continuity maintained, so the only option is that laparoscopy CBD exploration or particular PTC approach, but we go for laparoscopy or open CBD exploration. Then Mersey syndrome is a soft relative indication for CBD exploration because of difficult anatomy and increased risk of bile duct injury. So we should go for a CBD exploration if possible. Then what are difficult CBD stone? These are all soft indication for laparoscopic or open CBD exploration. Difficult CBD stone like multiple number of stone, barrel shaped stone, intrahepatic stones, or impacted stone, or the presence of a periveteran diverticula, or distal CBD stricture, or angulation of CBD is more than 135 degree. The manipulation of guide wire becomes too difficult in endoscope ERCP method. So we can go for laparoscopy CBD exploration. But we should remember that size is a not indication for laparoscopy CBD exploration. Many good endoscopists can clear 2 centimeter, 2.5 centimeter stone by ERCP by using endoscopic ESW, etc. So size criteria is a not for size is a not indication for CBD exploration. So at current practice, we usually follow where anatomy is not favorable, or ERCP not available, or contraindicated, or fail to clear the CBD. Then we go for a CBD exploration, laparoscopic or open CBD exploration. Then what are the surgical techniques? Laparoscopic approaches and open approaches. Laparoscopic approaches are laparoscopic transcystic approaches, laparoscopic transcollateral approaches, plus minus stent placement or T2 placement, and transduodenal CBD exploration, and laparoscopic bilioenteric bypass. And other open approaches like open CBD exploration with or without T2 placement, and transduodenal sphincteroplasty or bilioenteric anastomies like hepatico-jejunostomy. So at recent, mostly now we'll limit our talk to laparoscopic CBD exploration. So there are 4 methods of laparoscopic CBD exploration. First is transcystic approach. You can see the figure here. Can loop the cystic duct, then made a ductotomy in the cystic duct. Then through the transcystic approach, we cleared the stone. And these are transcystic approach mostly for very small stone like 5 mm stone, 6 mm stone, etc. And another criteria, cystic duct should be wide and dilated, so the stone can be extracted from the through the cystic duct. Then second approach is transcollateral approach. You put a direct incision over the CBD and to took out the stone. We'll discuss details later. Then another type is transduodenal CBD exploration. That means when there is the stone impacted in ampulla, and it's very difficult to clear the impacted stone from the ampulla via ERCP method or via laparoscopic approach. So you can go for a transduodenal exploration. You can open the duodenum, then incise the ampulla and extract the stone, and then go for ampuloplasty with or without ampuloplasty, sphincteroplasty. Sorry. Then another last but not least is bilioenteric bypass, like dilated CBD, primary cholecystectomy with dilated CBD of 3 cm, recurrent CBD stone. Then the best to go for a CBD exploration, CBD bilioenteric bypass like hepatico-jejunostomy. So successful CBD exploration, laparoscopic CBD exploration determined by three things. First, the most important thing is armamentarium. Like you should have any one of three available with you, like intracholangiogram, which required a fluoroscopy, which required OT fluoroscopy, or intra-ultrasound, and a cholecystectomy. Out of these three, one should be must there before you go for a laparoscopic CBD exploration, because you want to confirm that CBD is clear of the stone. Then surgeon expertise, and the surgeon must be expertise in the CBD exploration. And the third factor which depends the successful CBD exploration is tissue integrity and CBD diameter. You can do a CBD exploration, CBD inside the CBD diamond, CBD diameter is 6 mm, 7 mm, because it may lead to stricture in the long term. And the tissue integrity, if the tissue not holding the suture is getting got through, then we can go for bilioenteric anastomosis or other things. So next, these are a few images. So this is an intracholangiogram, and this is a cholecystoscope we usually use in ROT, and these are various laparoscopic probe which confirm which go for laparoscopic intraoperative ultrasound. So what are the basic steps of laparoscopic CBD exploration? First is patient and port positioning. The usual position which we follow in the cholecystectomy, steep reverse 10 position, head steep down position. And surgeon can be stand in two positions. Surgeon can stand in patient's left, just like in laparoscopic cholecystectomy, or many surgeon like to stand in between the leg, if it in between the leg. So surgeon can stand left side of patient or in between leg, but port positioning is similar to the which what we follow in laparoscopic cholecystectomy. Then second step is do a cholecystectomy and loop the cystic duct. Then if you are going for a transcystic CBD exploration, when feasible, that means stone is very small and cystic duct is wide, and through which stone can be removed, then we go for a transcystic CBD exploration. Then we cannulate the cystic duct. Then we remove the stone by Dormia basket or any Dormia basket or any guide wire through the guide wire, and always flush the CBD with saline to clear all the stone through all the stone. The second approach is choledochotomy. You made a incision over the CBD, and before incision, you must make the incision as low as possible in distal CBD, because if you make the incision higher above the CBD, if stricture form, it is a complex biliary. If there will be a stricture in future, it will be a complex biliary stricture. So before so the incision over the CBD should be as low as possible, and the length of the choledochotomy should be around 5 to 10 mm or 1 to 2 centimeters. Then we go for CBD exploration, and we'll detail discuss this in video. And what are the method of removing the stones? First, there is Dormia basket. We use a basket to lift the stone and keep it out of the CBD. Then another urgent is Fogarty balloon. We put a Fogarty balloon in the CBD and pull out the stone, or we can use the infrared feeding tube for flushing the stone to the duodenum, or mechanical lithotripsy if available. Then this is short animated video disclosure I have taken it from internet, which can explain what are the different CBD clearance method. First, the classical, you go for ERCP, then cholecystectomy. This is you can go for cholecystectomy and followed by ERCP. Then this is the CBD exploration method. You made a cholecystectomy, you put an incision over the CBD and remove the stone. This is a transcolloidal CBD exploration method. Next is this is a transcolloidal approach. As I explained before, you put an incision over the CBD and remove all the stone. So as I explained, there are three to four methods of removing the CBD stone. You can see one by one. This you put the incision over the CBD, you remove the stone by any grasper or forceps. The next method is chopstick method. Take two grasping instrument and push and press the CBD, stone will pull out. The stone will be pushed out of the CBD stone. The third method is laparoscopic cystic dot exploration, transcystic approach. You put a nick over the cystic dot and remove the stone. This is the transcystic approach, where you put a nick over the cystic dot and remove the stone. And this is the intra-op ultrasound method. You will use this is a very good image showing. This is a Mickey Mouse image in the intra-op ultrasound. When you put an ultrasound over CBD, the below and put a color Doppler on, you can see this is the portal vein, this is the common hepatic artery, and this is the common bile duct with some hyperdensity in the common bile duct is a stone. So before before giving incision over the CBD, you must remember that over the CBD in the 3 o'clock and 9 o'clock direction, there are arterial supply to CBD. So avoid making incision just at 3 o'clock or 9 o'clock position, or it will bleed torrentially. So always make incision in the mid CBD below the cystic duct, as low as possible, and around 1 to 1.5 centimeter depending on the stone size. Then you remove the stone by any method I described before. This is the intra cholecystoscopy. You should, or a cholecystoscope with wire basket. This is the Dormia basket I was talking about. To use a Dormia basket to pull out the stone. This is transcystic approach. Okay. The last step of CBD exploration is always to confirm the CBD is clear of the stone, either by cholecystoscope or intra ultrasound or cholangiogram, whatever the facility you are available with you. Then I will discuss a case. Is a 65-year-old male with a history of laparoscopic cholecystectomy present with severe cholangitis, and MRCP was done, which revealed a cystic duct stump calculi with CBD stones. As patient was in cholangitis, so patient underwent ERCP and biliary drainage for cholangitis. But in ERCP, stones were not clear. Endoscopists were not able to clear the stone. So after preoperative workup, patient underwent laparoscopic CBD exploration. So so this is a short video of how we do it in an SGBGI. So in this patient, there are multiple CBD stone, there are multiple episodes of cholangitis. So there you will find a dense adhesion between the omentum, colon, and liver. All these structures are densely adhered to the parietal wall and liver. So first, before putting any port, there is no space available where to put a port. So first, you will after careful fine dissection, you put your standard laparoscopic port. You can see the adhesion, the extent of adhesion there. All duodenum, omentum, colon, all are added to GB fossa and HDL because of repeated episode of cholangitis. So you go for a both blunt and fine dissection, and carefully without injuring any colon or duodenum or any bowel. So you can see after so much adhesiolysis, you can see some whitish structure visualized in the HDL region. So then you will go carefully add more, will dissect more. So after much more dissection, this is the structure visualize. This is the structure. So you can see this is the CBD, and the lowermost structure duodenum, the crescent-like structure, and this is the cystic duct. The patient underwent laparoscopic cholecystectomy before that. This is the cystic duct with stump, and this is the CBD. So after dissection, we can see this is the cystic duct stump, and the cystic duct was cut with a harmonic. You can see this is the cystic duct opening. And this lower one is the CBD, white structure is the CBD, and this is the cystic duct opening. This is the CBD. So then through the cystic duct opening, we'll put a cholecystoscope here. Now we'll enter the cholecystoscope here. This is the cholecystoscope. We put a cholecystoscope here to look out for any CBD stone. So this is the cholecystoscope figure. You can put this is a huge stone in the distal CBD, and you can see the nearby yellowish structure is stent. So the previously placed stent. This is a stone, huge stone in the stent, and this is a proximal hilum towards the hepatic duct and the intrahepatic duct. You can see clear hepatic duct in the liver toward the hilum surface. So as you confirm that there is one stone in the distal CBD, now we'll go for CBD clearance. First, actually in this case we use many Dormia basket, but usually we were not able to clear the stone. So this is a chopstick method. You take two grasper and push the CBD so the stone can be come out. The stone is so large, so we extend our incision over the cystic duct towards the CBD. You can see we are extending the incision towards the distal end of the CBD, not the proximal hilum. So this is the stone, huge stone. So again we use a chopstick method to remove the stone. So stone is now removed. Now we are left with the CBD choledochotomy. Then again, I have to the last step always to confirm the CBD is clear or not. So we put a cholecystoscope here. This is a special instrument to scope is very friable. So this special instrument to prevent the breaking up the scope. Now the last step is to close the cystic duct. The best suture is monofilament suture 304050 and delayed observable monofilament suture like PDS or PDS suture. You can take 304050 depending on the wall of the CBD. If CBD wall is thick, then you can go for 30 PDS or 40 PDS. Is very thin CBD wall, then go for 50 PDS. So monofilament delayed observable suture is the ideal suture, but many surgeons prefer vehicle also. So this is depend on the CBD in the wall CBD's integrity wall of the CBD. So and as the patient already has a stent, so we just repaired the CBD. If the CBD, you can go for a stent placement, internal stent, or you can go for T2 placement. Then this is the final final closure of choroidotomy. Then you remove the stone by endobag using endobag. Then always thorough lavage and placement of drain in these complicated cases is must. So coming to outcome of laparoscopic CBD exploration, success rate is 83 to 96% in various studies, with morbidity like bile leak and in 5 to 10% of the patient, and the delayed complications are like biliary stricture, bile leak, and written stones, and mortality rate is less than 1%. And the advantage is easier access to both. In this laparoscopic CBD exploration, we can access both upper and lower ductal system, and you can clear the large stone through the CBD exploration. So coming to the recent hot debatable topic is whether we go for a laparoscopic cholecystectomy with laparoscopic CBD expression at a one-stage procedure, or we can go for ERCP followed by laparoscopic cholecystectomy. Various multiple studies are there, and they found that equivalent success rate between the ERCP and the laparoscopic simultaneous cholecystectomy and CBD expression. And as a single stage procedure, laparoscopic cholecystectomy CBD expression associated decreased hospital stays, fewer cost effective, fewer cost, and shorter length of hospital stay. But the problem is technical challenge. Not many surgeons are oriented with the laparoscopic CBD expression technique. So various study in India and outside many found that laparoscopic CBD expression are equivalent success rate with ERCP followed by laparoscopic cholecystectomy. To conclude my talks, surgical management of remain crucial in a CBD stone despite emergence of advancement of endoscopic technique. Laparoscopic CBD expression offers a highly effective and efficient alternative cases, particularly in complex cases. Laparoscopic CBD expression is a technical challenging procedure. The problem persists due to unavailable expertise and technical challenge. And the cholecystoscopy, cholangiogram, and ultrasound are must to ensure a complete ductal clearance. Thank you.
Thank you, Dr. Sarangi. I think he has covered majority of the things in laparoscopic CBD exploration. So I feel there are no questions in the chat box. So
Boss, Dr. Rahul, there is no question as of now in the chat box or in YouTube. So if you can discuss some question which might interest MS General Surgery postgraduates and some discussion, or else we can go to the next talk.
Yeah,
and
one
Dr.
question.
Avinash, okay, Dr. Shankar, one more minute before we take in. Like Dr. Avinash Gautam has joined, he's a rapporteur. So, Dr. Shankar, please go ahead and ask your question, please.
Yeah, in case of Meritzi different levels, how do you manage and investigate, sir? Hello? Hello?
Yes, Dr. Shankar.
Yeah. Am I audible, sir?
You are audible. What is your question to Dr. Rahul?
Meritzi different stages. How do you manage the case by laparoscopy or open procedure is better? There are different stages are there, 1, 2, 3, 4, especially 3 and 4. How do you manage, sir?
Okay. Dr. Sarangi, will you take that question? Is Dr. Rahul connected?
Hi, Dr. Prashant. Dr. Prashant, can you hear us?
Hello.
Yes, sir. I can hear you, sir.
Yeah. Yeah. Meritzi syndrome, how do you manage whether it is laparoscopically or open procedures based on the stages of Meritzi?
he is asking Miriji syndrome. How will you manage it, by open or laparoscopic thing करके?
So, Dr. Sarangi,
Okay.
Dr. Sarangi, are you there?
Sir, can you hear me, sir?
Yeah, Kush, you can answer that question, please.
Okay. Sir,
Sir, it's Dr. Sarangi only. He's answering the question.
Yeah, sure.
Thank you.
Sir, for Miriji, first we have to go for a detailed imaging, like MRCP, to delineate it is a type 1 Miriji, there are type 2 Miriji, type 3 Miriji. So in type 1 Miriji, there is a extrinsic compression of the cystic duct stone over the CBD. So there is no communication between the cystic duct and CBD. In type 1 Miriji, you can go for laparoscopic cholecystectomy, careful laparoscopic cholecystectomy. It is not easy procedure because the cystic duct is densely adhered to the CBD. So possible to go for laparoscopic cholecystectomy. And if there is then we found a type 2 type 3 Miriji, like, or we can go for a laparoscopic type 2 type 3 Miriji. We can get laparoscopic cholecystectomy or open cholecystectomy with choledocoplasty. We take a wall of GB and repair the hole in the CBD. Or in the type 3 Miriji, type 4 Miriji, then it's best to go for a bilioenteric anastomosis like hepaticojejunostomy.
Okay, sir. Yeah, better as you go up stage 3 and stage 4, you go for open procedures only is better.
Yes, sir.
Safer.
Safer to go for open hepaticojejunostomy.
Okay. Thank you, sir.
Thank you.
Thank you, Dr. Shankar, for that question. And if it's no more questions, then I don't see any. One chat in chat box, please. Okay, this is from Dr. Rahul. So there is, if no more questions, then we go to the next talk, and Dr. Rahul will introduce the next speaker.
the next speaker is Dr. Prashant. He is assistant professor in surgical gastroenterology in SGPJ. So he'll be talking on laparoscopic safe cholecystectomy and bailout procedures in cases of difficulty. So over to you, Dr. Prashant. Please proceed.
Yes, sir. Thank you, sir. Good evening, one and all. Now I will going to deal with the laparoscopic safe cholecystectomy and bailout procedures. Regarding this thing, actually, instance of complications during a laparoscopic cholecystectomy is like impossible to determine due to we don't have any registry for the laparoscopic cholecystectomy and no reporting regarding the complications. But worldwide reported incidence is around 6.8 to 7.7. But in India, the percent can be go raise up to 14 to 20% around. What is a safe cholecystectomy? In the safe cholecystectomy armamentarium, we had defined anatomy, we had defined aberrations regarding the anatomy and their aberrations, and we have a bailout procedures, defined bailout procedures, and we know the critical view of safety, and we know the how to use of cholangiogram, and we also know the difficult prediction of what is easy and what is a difficult procedure, and we also know the know the WTO of critical view of safety. Coming to further intraoperative procedure, we have to know the anatomy of the intraoperative anatomy of the gallbladder, what are the structures it is bounded off, and we have to know the critical structures where we have to be careful during the dissection. Like gallbladder usually lies between the segment 4 and segment 5, and it is like critical structures like Ruvier circus where usually right posterior pedicle will be going off, as well as to the medially the main important structure is a CBD as well as a right hepatic artery. We have to mainly focus on these structures to prevent the injury further during the dissection. And we had to know the hepatocystic triangle where our dissection should be confined within the space to prevent the further damage, and how to confine how to dissect in this space. We have to clearly stick to the few principles, few defined lines which I will be coming further. The hepatocystic triangle usually bounded by a base of the liver, followed by a cystic duct and a CBD. In this, we will able to see the fibrofatty tissue, which contains of two as a cystic artery and a cystic node. Coming to the important landmarks, like I already previously discussed, like Rouvier circus, segment 4 base, and a CBD, which we have to be clearly defined. Regarding the R4U line, this is an imaginary line which is very important during our dissection to achieve a critical view of safety. Especially, there is this line usually drawn from the Rouvier circus, crossing over the CBD, followed to the segment 4 base, where the dissection line should be always in the above the R4U line to achieve a critical view of safety. We should not come below. Before commencing that, we had to address notice that be safe is a mnemonic to address the to notice these structures like bile duct, base of segment, sulcus Rouvier, segment 4, followed by artery hepatic, fissure umbilicus, and any enteric structures like duodenum or a stomach. These structures has to be noted before commencing the further dissection. There is in case of simple cholecystectomy, the R4U line will be helpful. In case of acute cholestasis, where there is a frozen callots, where we have to do a dissection, here the D line is a diagonal line, which is like a defined in a complementary guidelines for the Tokyo of the Tokyo guidelines, where this line is also an imaginary line drawn from the sulcus Rouvier to the segment 4, where we have to stick to the dissection. It is not to achieve the critical view of safety, but it is to achieve the anterior posterior window to make further steps like do any subtotal cholecystectomy, or if we able to achieve if we able to visualize the cystic duct, we can able to clip that and divide that. This is a D line, diagonal line, where we have to stick to the above and we have to open anterior to posterior way. Here we should not able to try to delineate the to look for any cystic duct or cystic artery. What is the critical view of safety, which was defined by the Strasbourg previously? It is a very helpful and helpful principle to prevent the injuries to any aberrant anatomy or aberrant any right hepatic artery or CBD. Here, it is a critical view of safety mainly consists like clearing of the fibrofatty tissue, like anterior and as well as posterior, and lower 1/3 of cystic plate should be cleared off by lifting the gallbladder from the cystic plate, followed by any tubular structures. We have to notice that only two tubular structures has to be entered in a 360-degree view, so that we can further clip and divide the cystic duct and a cystic artery. And regarding the further going into the surgical steps, we have to know that when we have to take the time out during a laparoscopic cholecystectomy, it is like a before entry into the abdomen to look for any port site injuries or dissection. Before the hepatocystic triangle, we have to note down the critical anatomical landmarks where we are doing a dissection, followed by any anatomical ambiguities like any aberrant anatomy, we have to note it down, followed by we have to during the achievement of critical view of safety before clipping the duct and artery. Surgical options regarding this thing, concerns are like regarding the timing. This not for a simple cholecystectomy, it is for a acute cholestasis, whether we have to go for a within less than 3 days or after 6 weeks. This has to be keep in mind whether we have to go for a lap versus open procedures. Like laparoscopy for a simple case is good enough. For in case of any difficulty and lack of expertise, we can go for open procedures. And we have to know the bailout procedures, which helpful in bailing out in a difficult situation. What are the options available in our in the armamentarium, and we have to go and we have to choose that in a right way. Regarding surgical steps, in a laparoscopic cholecystectomy, important thing is a port placement is a very important for maintaining the angle between the instruments, which prevent the filling in the intraoperative environment. Here it is defined in a Woodwardia, the father of a laparoscopic surgeon in India. He has defined a proper placement of the ports. One is like a camera port is in the umbilicus, which require a 1 centimeter incision, followed by epigastric port, which usually placed at the junction between the 1/3 and 2/3 in the midline, below the xiphisternum. followed by one is retracting two working ports. One in the right midclavicular line, which is 2 centimeter below the costal margin, followed by one is lateral retraction, gallbladder retraction port, which usually we place in the right mid-axillary line, 5 to 8 centimeters below the costal margin, but this should be confined, it should be above the umbilicus. Followed which, now I will show a short video regarding the laparoscopic cholecystectomy, the steps, simple steps, how we have to go to avoid any injury further. After entry into the abdomen, after ensuring that there is no port site injuries, followed which we had assistant asked to grasp the GB, usually at the junction between the fundus and the body, if it is a long gallbladder, and the tip of the shoulder, tip of the instrument should be pointing towards the right shoulder, so that it will splay out the callots. And always incision should be made at the level of a free fold of the gallbladder peritoneum, where we can go and we can ensure the further dissection into the adhered principles. Here we can take a hook, or we can take any bipolar device also. And we have to usually score the peritoneum at the level of this infundibulum or a neck of the gallbladder. First incision should be always, scoring should be always done at the infundibulum or the neck of the gallbladder. Then further step will be, and after incising the free fold of peritoneum, the further dissection will be commenced in the posterior plane. Here, we have to before commencing the posterior plane, we have to note the these R5U line. If it is a case of simple cholecystectomy, we have to note this thing, and we have to strictly stick to the principle above this line. Our dissection will be going snugly close towards the gallbladder. It is not towards the liver bed, or it is not towards the downward below the Ruvier sulcus. And now the dissection will commence toward the posterior callots. Here the retraction instrument should be always towards the upward and medial position. The retraction of the infundibulum should be upward and the medial position, so that we can able to identify the posterior callots, and we can able to easily dissect the posterior callots. And we have to remove the fibrofatty tissue, and we have to score the peritoneum, and we had to divide it way up to the liver bed, cystic bed. This is a very critical step. We have to always point the hook towards the outside, not to point the hook towards the outside, because it will the base of the hook will damage the gallbladder, and it will make the field messy. So always remove the tent and cut the fibrofatty tissue or any layer. Any bleeding can be cauterized with the monopolar, and we had to divide the fibrofatty tissue. And care should be taken. We should not enter completely. We should not enter completely from posterior to anterior. Only we have to remove the fibrofatty tissue, followed by we have to see the cystic duct, and we will shift to the anterior plane. For anterior plane, we have to note that our direction of the retraction should be the downward outward. Usually towards the left side. This will be helpful to splay out the anterior callots, and will helpful to visualize the thin layer for further dissection. And we'll score the anterior layer, and care should be taken. We should always start the incision at the junction between the cystic duct as well as the cystic artery, and we will score the peritoneum continue toward the cystic bed. Always tent and bust the peritoneum to avoid any injuries. And follow which to delineate the cystic artery as well as cystic duct, we had to clear the in the upper triangle where we had to clear the fibrofatty tissue. Here, care should be taken. There will be a artery to duct, which inadvertently we will injure during the dissection. Here we can see this thing, artery to duct. It has to be burst. Then we had to cut that. Sometimes if it is large, we can clip and we can divide the structure. Usually, in our institute, we usually burst this structure and we'll divide this thing. Always make sure that the tip has to be pointed as a mosquito, and we should not pinch a bulk of tissue at a time. We should just pinch a small amount of tissue, then burst, and then further proceed. Multiple times we had to do a dissection, followed by after achieving a plane, after ensuring that there is no vital structure, then only we had to go for buzzing and well the dissection. After ensuring the cystic artery, then we will try to divide the anterior part of the callots further towards the cystic bed. Here, care should be taken not to injure the cystic node, because there will be a bleeding, a chance of bleeding will be there, which make the field messy. Here we can use a hook or we can use a cautery, but any dissection has to be snugly close to the gallbladder, not towards the CBD, towards the hilum. And here there is no need for to delineate the CBD. Our dissection should be confined to the callots. We should not go below the rever sulcus. The point has to be noted. And clear the fibrous structures above the cystic duct to ensure that proper placement of the clips. And here the critical view of safety is not yet completed. Only the part left is that we have to clear the lower 1/3 of the cystic bed to ensure that there is no other abnormal ducts or any abnormal vessel going and dipping into the liver here. After achieving posteriorly, the same peritoneum has to be scored anteriorly, and GB should be lifted off from the cystic bed. And it will show the critical view of safety, where we can notice here after we are clearing the cystic bed.
Sir,
And
here, can you explain in the live way where is the critical view of safety?
yeah, sure.
Yeah, because when you are dissecting, you can tell us.
Yes. The critical view of safety, which we it has the three components. One component we already has done that, like clearing of the this thing fibrofatty tissue near the callots in a posterior as well as in the anterior in a defined principles, like downward, outward, and for anterior callots, and upward and towards the medial side for the posterior callots. We had cleared every structure. Followed which we are able to see only two structures going into the gallbladder here. Where we can see.
Yeah.
I'll show that. Wait.
Yes.
Here, 1 second.
Nice dissection.
Yeah, 1 second. I'm not able to stop exactly at this thing. Yeah. See, here we are able to see only two structures. One is the cystic duct, one is a cystic artery, and we had removed the fibrofatty tissue in these anterior calloids as well as in the posterior calloids. Now, if you're able to see 360 degree, only two structures are entering into the gallbladder. One is a cystic duct, one is a cystic artery, and there is we can able to see the liver base from anteriorly, as well as if we flip towards the posteriorly, we can able to see the liver base from the posteriorly also. But to complete the third step, we had to at least clear the GB from the cystic bed. At least lower 1/3 of the cystic plate should be cleared to ensure that there is no any aberrant arteries or any ducts opening here. That is the critical view of safety. We achieved here almost.
Yeah, thank you.
Okay. See, almost from posteriorly, we are also able to see the liver base of the liver here. So sticking to these principles are very important, and confined to the R for U line, and our dissection should be above the R for U line, so that we will able to achieve the critical view of safety in case of simple cholecystectomy. And after this, we had to clip the duct. Some surgeons might be tying the duct. Some surgeons can use the hemolock. Some surgeons will use the clip, or directly they will do with the harmonic also. But harmonic is not preferable for the duct. Only for a small artery, then we can go and do a harmonic. But for a duct, make sure that we have to tie, or we have to put a hemolock, or we have to put a clip.
Shall we discuss a couple of points here, sir?
Yeah.
Yeah. Always keep the area safe, and see that you are only dealing with the gallbladder. You have to moving up the instruments in the field only.
Yeah.
And before you lose the field, you have to be careful, slow and steady, especially for the beginners as well as senior most people. And these are the few points you have to see. Go slowly, especially when you are going into the troublesome areas, and like common hepatic duct, cystic duct abnormalities, and vascular abnormalities. Anything abnormal, you see that, go watch, and then decide, rather than committing initial stages. All these safety precautions are very important. The safety is doubly important, because once you get into problem, that will that will enhance. Whole field will become difficult. Please carry on, sir.
Yes, sir. And after this, we had to clip the duct and artery. Always ensure that there has to be two clips below the towards the CBD side, and one clip above the duct side, cystic duct, to ensure the further leak, prevent the further leak. And follow which artery has to be clipped above and below. And always ensure we have to cut the cystic artery first to avoid the tension over the cystic artery. If you cut a cystic duct first, so make sure that cystic artery has to be divided first, followed by cystic duct.
Good points.
Yes. After dividing the duct, ensure that calloids, the clipped area is there is no ooze or any. If we have missed any posterior cystic duct, which usually arises, which usually missed by the surgeons, we have to ensure that is there any other bleeding structure. We have to clip that structure also. Followed which we have to remove the GB from the GB bed.
One question, sir. When
Yeah.
you have a frozen calloids, how do you approach that, sir?
Frozen calloids, yes, sir. I will be coming in the. There is a few videos are available, sir. I will be showing in subsequent slides, sir.
Yeah, just for the
There is
postgraduate, just to discuss.
already I had discussed prior. There is a D line which is a complementary guideline defined for the Tokyo guidelines, where this is the imaginary line where in these frozen callots we could not able to try to delineate the cystic artery or duct. Here the callots is frozen. If we do so, the bleeding will be torrential and we cannot able to control the bleed. That will be difficult. But they have described that this is the diagonal line where if we go do a dissection above here try to make a window from anterior to posterior between the gallbladder and liver bed, like a cystic plate. Try to create a window so that we could able to cut the gallbladder, or we could able to directly apply the our staplers directly, so that it will be constituting like a fenestrating or a reconstituting type of a subtotal cholecystectomy. It is a kind of a bailout procedure in that situation. If you try to go and delineate the callots, then we will be land up in a trouble. Or sometimes in some acute situations where we can able to delineate the cystic duct, not an artery, then we can able to directly clip the duct and we can divide the gallbladder.
Yeah.
Coming to difficult cholecystectomy, as there is no defined consensus prior to the Delphi project, there in a Spanish experts, a group of experts with the two-round questionnaire, they had defined that up to 80%, above 80%, they shows the unanimous agreement, and they had given that preoperative factors like a Merzey syndrome, time of the last acute cholecystitis, like preferably like difficult in the more than 3 days, and scleroatrophic gallbladders where the gallbladder will be shrunken in a chronic cholecystitis, as well as in a pericholestic abscesses or any liver cirrhosis. And intraoperative factors like they said like bile duct injuries, like no non-evident anatomy when a surgeon operating in remote areas, or severely inflamed callots, or any conversion requirement to laparotomy or a surgical time more than 60%. This is a defined consensus for a difficult cholecystectomy. What are the bailout strategies for the difficult gallbladder? Where a surgeon operating in remote areas, he can face the difficult. Not every gallbladder is simple. He can face any difficulty. In that situation, he has an option of abandoning the procedure, or he can convert the laparoscopy to open procedure, or he can do a subtotal cholecystectomy, or he can do a fundus first cholecystectomy, or he can directly put a tube cholecystectomy and relieve the patient's sepsis, and followed by further interval cholecystectomy. These are the bailout strategies for a difficult gallbladder. In that subtotal cholecystectomy, there are also two types. One is like a fenestrating, and another is like reconstituting. Fenestrating is nothing but we'll open the gallbladder and we'll ablate the mucosa, and we don't suture the gallbladder here, but we can take a suture towards the cystic duct if any bile is coming out to prevent the further leaks. In case of reconstituting, we'll cut the gallbladder and we'll directly suture, or we'll directly staple the gallbladder depending upon the availability. Here, there's a small video of fundus first technique where these videos like field is somewhat messy due to dense adhesions. We need most of the time we will use the bipolar devices or any harmonic devices that will be helpful to achieve a hemostasis. Here we'll start the fundus first technique by dividing the gallbladder as well as cystic between the gallbladder and cystic plate from the fundus. Here care should be taken not to injure or not to injure any gallbladder, or not to go into the liver bed. We'll try to delineate the duct here, and after removing the gallbladder from the gallbladder bed, we'll try to delineate the duct. If it is possible, then we can able to clip the duct, and we should not care should be taken. We should not tend the gallbladder too much during the clipping. Otherwise, we'll able to, if CBD is going to tend, we'll able to divide the CBD also. So care should be taken. Don't put too much traction over the gallbladder. Followed which we can some surgeons use a suture, or some surgeons use a clips to divide the gallbladder. Before these are based on their preferences, and we'll remove the gallbladder. This is a kind of a bailout procedure where we cannot able to delineate the callot structures. We can do a fundus first technique. all of which I have a short video regarding the tube cholecystostomy, where we can use a Foley's or a Malacor. Here, if the bowel and there is a dense adhesions, like it's a emergency life-saving procedure, where we can able to relieve that gallbladder tension or any pus to decrease the sepsis. We'll just make a nick over the fundus of the gallbladder, and we'll just put a Foley's, and we'll inflate the Foley's bulb. And we will ensure that it is not coming out after inflation, and we will connect the Foley's to the drainage. One more is a subtotal cholecystectomy. Here again in subtotal cholecystectomy, the field will be very messy, and we have to carefully we cannot able to retract the gallbladder because of the thick fibrous adhesions, and even we cannot able to delineate the callots. So there is no harm in opening the gallbladder in this case. Always here we can able to, if you are able to do a there is a two approaches. One is the D line approach, where if you are able to create a window from the anterior as well as towards anterior to posterior above the rear sulcus. If you are able to achieve that, that is good for to apply a stapler. After if you notice that if we after achieving a window from a anterior to posterior side, we can directly apply the staplers over the infundibular area, so that rest of the gallbladder we can remove easily. This is a application of stapler. And now we can see the callots area where the GB is sealed off completely, and we can ensure that there won't be any further leaks, and drain has to be placed here, and GB is removed. This is a type of one more short video. This is a type of fenestrating approach, where in case of difficult gallbladder, we can make an incision over the anterior towards the serosal side of the gallbladder, and evacuate the contents or stones within it. And always try to use a bipolar devices or any harmonic devices to ensure the edge bleeds, to prevent the edge bleeds. After which we can able to see that there's a large stone stuck at the infundibulum, and we have to remove that. And rest, if in this procedure, if we are able to notice any opening here, we can take a suture. Or if there is no opening here, do not try to fiddle much here, and try to ablate the mucosa, which you can see, visualize. Usually the posterior wall of the gallbladder. And try to place a drain, so that if there any bile leak or anything, we can drain that out, and we can plan for further ERC stunting. And my take-home message is that the overconfident surgeon in the easy case spell a danger. So always never think that every gallbladder is easy, or any major damage will happen in an easy case when the surgeon will do an very hurry up way. And points to be noted is that these are the defined landmarks are there, where we had to go, we had to dissect, and where we had to we had to confine to our dissection. And the adherent to the principles that is given in our Woodwardia, where we can which is beautifully written there, where how to approach the callots, and how to get the critical view of safety. And timely assessment, like any intraoperative difficulty, you should not go further dissecting, which which helps the surgeon to be fatigued, followed by surgeon can be fatigue, and he may harm the more other structures. Thank you.
So thank you, Dr. Prashant, for a comprehensive discussion on safe laparoscopic cholecystectomy.
Thank you.
So one thing is most important for the beginners and those surgeons who have just started doing independent surgery. It is important that the most important bailout procedure in laparoscopic cholecystectomy is conversion to open or just abandoning the procedure if you're not able to progress further. And another important thing is how you choose your patients. So you should not go for cholecystectomy after 72 to 96 hours of onset of acute cholecystitis. You should not do cholecystectomy in a patient who has in periphery if you do not have good armamentarium, good light source, good laparoscopic instruments, and it is always uh, wise to take help from others if anybody is around, if you are caught in a catch-22 situation. And the most important thing in safe cholecystectomy is timeout. So you should always ask your colleagues or the camera person or the even a junior who is assisting you during the surgery if you are going well. And important timeouts are when you enter the abdomen, especially when you take up the patient, when you enter the abdomen, when you are dissecting on the calyx and you are about to clip the artery and the duct, you should always confirm from your partner whether you are doing correctly or not. So that's all from our side. If there are any questions, we are happy to take those questions. If there are none, then we can move forward because we are lagging on time. So I could not see any questions in the chat box. If anybody wants to ask a question, you can please go ahead. So if there are none, we move on to the next speaker. And I invite Dr. Payal to present her views and thoughts and methods of doing hydrolysis surgery in especially hydrolysis liver, in which how to manage those patients and what are the current management principles. So she will be discussing on hydrolysis liver. She is again assistant professor in surgical gastro at SGPJ. And over to you, Dr.
Good evening. I'll be talking about hydrated cyst of liver and their biliary communication and the management. Hydrated disease of liver. Hydrated disease of liver is a zoonotic disease caused by Echinococcus parasite, and as we know, the adult of this parasite resides in the definitive host, that is the dog and other carnivores. These adult worms, they lay eggs, and it is infected. The infected eggs are ingested by the intermediate host, that is the sheep, goat, and the swine, where the larva stage matures, and the cascades of these animals are further eaten by the carnivorous animals for completing the cycle. Humans are the accidental host in this cycle, and we can infest this infection through unwashed raw vegetables or by close contact with the definitive host. It is important to us in India because India is an endemic region for hydrated disease, and the diagnosis of this disease is made based on the history, serology, and radiology. To confirm the case, either the patient should have two positive serologies of hydrated disease, or we should have demonstrable protoscolase or their components under direct microscopy or molecular biology. The basic history of these patients is usually asymptomatic, and they have non-specific symptoms like nausea, sometimes vomiting or pain abdomen, which is non-specific, and it is usually as an incidental diagnosis that we find these cases. The symptoms can sometimes occur due to secondary complications like compression, due to obstructive jaundice, pre-sinusoidal portal hypertension, or secondary Budd-Chiari syndrome, or due to infection in the cyst, rupture of the cyst, and erosion into the bile duct, pleural spaces, peritoneal cavity, or communication in the digestive or bronchial systems. Serology, it is very non-specific because India is already endemic. So only 30 to 40% of patients will have no detectable antibodies in their serum. Antibody detection remains the method of choice, and most specific antibodies antigen B and antigen 5. Primary tests are ELISA, that is very frequently done, and it has a sensitivity of around 80 to 95%. And secondary tests include ARC5, immunoblotting, and PCR tests. They are more specific, and post-operative seronegativity is usually reached after 3 to 7 years. To classify these lesions, the radiological classifications that are used are Garby's classification and WHO classification. Garby classification is an ultrasound-based classification, which is historical currently, and it classifies the cyst into 5 types. Type 1 is the unilocular or unechoic cystic lesion with double line sign. Type 2 has cyst with detachable membrane, that the famous water lily sign. Type 3 has multiple septae or rosette-like honeycomb cyst. Type 4 is the one with heterogeneous hypoechoic or hyperechoic content but doesn't have any daughter cyst. And type 5 is solid cyst with calcification. WHO classification, which was in 2021, it was formulated, and it is similar to Garby's classification. However, there is slight change, that is the Garby type 2 is CE3A, and Garby type 3 is CE2. And they have added a Garby type 3B, that is cyst with multiple daughter cysts in the solid matrix. The WHO classification is actually relatively better to use in common practice because this classification can be applied to all the imaging modalities, that is ultrasound, MRI, and CT scan. And it is more accurate for functional staging of the cyst. So for CE1 and 2, it's the active cyst. CE3A and 3B are the transitional, and CE4 and 5 are inactive cyst. So for CE5, which is calcified cyst, if we are able to diagnose that, we need not do anything further. So it is important to know the functional status of the parasite and the activity. Natural history of hydrated cyst. CE1 cyst can directly form into a CE3A, that is detachment of membranes can occur, or there can be septation in the cyst, that is CE2, or it can further form into CE4 or 3B, and ultimately the final stage is CE5, that is the calcified cyst. So the cyst can evolve and grow at a rate of 1 to 1.5 millimeter per month, ultimately leading to rupture, or it can age and with progressive involution and calcification. The main goal of management of a hydrated disease is to ensure complete elimination of the parasite, prevention of recurrence, decreasing the morbidity and mortality related to it, and management of the complications, including cyst infection, rupture, erosion into neighboring structures like bile duct. So the main focus of today's discussion is the surgical management. However, we have medical management, pair, and surgery as options. Medical management is usually given as albendazole 10 to 15 milligram per kg body weight. Albendazole inhibits the uptake of glucose by the parasite, and it inhibits the production of adenosine triphosphatase. The pair It is indicated for cysts which are more than 5 centimeter in size, but limited to cyst size of around 7 centimeter. Because larger the cyst, more is the chances of cystobiliary communication. So pair is avoided there. So next, the basic today's point is surgery. So surgical management is indicated in cysts with large, which are larger in size, CE2 and 3B cyst with multiple daughter cyst, superficial cyst, which are or they are complicated cyst. It is contraindicated in patients with, who are have contraindications to surgery, uncomplicated C4 and 5 cyst, and a very small cyst. Basic principle of surgical management includes total removal of all the infective components of cyst, avoidance of spillage of cyst content, management of communication with adjacent structures, management of residual cavity, and management of surgical risk, including the post-operative morbidity which can come with the cystobiliary communication. There are two types of surgeries, conservative and radical approach. In conservative approach, partial cystopericystectomy is done. That is, the pericyst is left in situ. Pericyst is the layer which is formed as a reaction to the, it is formed by the host as a reaction to the parasite. And it is left in situ in case of conservative surgery. This surgery is most commonly performed worldwide. Radical surgeries include total pericystectomy, near total cystectomy, and hepatic dissections. Surgical approaches can be either open or minimally invasive. And today I'll be discussing about the approaches laparoscopy versus open. In the current era of laparoscopic surgery being evolving in all the fields, even hydatid cyst laparoscopy is taking over. But we need to know that laparoscopy has challenges of spillage and anaphylaxis, especially with hydatid disease. First laparoscopic disease surgery was performed in 1992, and soon after the first report of anaphylaxis came. 5 years later, another a report of anaphylactic shock complicating the laparoscopic surgery, and patient had died in that procedure. Subsequent to that, laparoscopy had taken a back foot in management of hydatid disease. Later studies established it to be a safe and feasible option, avoiding laparotomy, but in selected cases. This is the data of multiple series. These all series are of more than 20 patients, and none of them is a randomized trial. This suggests that overall conversion to open is around 5% in these cases. And what is an ideal case for laparoscopic management? An ideal case is a one who has uncomplicated cyst located in the anterior segment, preferably in the liver periphery, away from the major vessel and ducts. An unsuitable case is one with intraparenchymal disease, with intraparenchymal deep cyst, inaccessible recurrent cyst located in the posterior segment or close to the major vessels, cyst with thick calcified walls, infected cyst with septic patient. These are various laparoscopic systems that have been established over time, including the Pelani-Willow hydatid system. The one on the right side is the system that we use at our setup. It includes using a max flow suction irrigation device, long ribbon gauze, and an endo bag. Now I'll be demonstrating the procedure, laparoscopic hydatid cystopartial that's done in our setup. This is a case of 66-year-old female who was incidentally diagnosed to have a left-sided hydatid cyst. Patient position. Patient was made to lie in the reverse Tendelbach position, and surgeon, since it was a left-sided cyst, it was comfortable for surgeon to operate in the while standing in between the legs. Although we can use different positions based on the location of the cyst. If it is a right-sided cyst, we can perform as standing on the left side of the patient. To begin with, the subdiaphragmatic dissection was done. Minimal dissection was done just to create a space around the cyst cavity. Sorry. Minimal dissection was done to create space around the cyst cavity so as to place the gauze piece, which was impregnated with scolicidal agent. In this case, we have used 10% povidone iodine. We can use a hypertonic saline as well. But usually we have 10% povidone iodine, and it is preferable also because in case there is any spillage, the gauze, the color of the gauze will change and will be more cautious. Then a controlled cyst aspiration is done to inspect for the contents. We'll see if the contents, if there is bile. Subsequently, endobag is placed and the assistant holds it in vicinity of the cyst cavity. Cyst is open in a non-dependent position, and the contents are removed. The daughter cysts are removed in the endobag, and we'll place the high suction flow in the and aspirate the contents. These jiggly movements are important so that the suction doesn't get blocked and it avoids spillage. Once we're sure that maximum content of the cyst cavity is aspirated, we'll further do the partial cystopericystectomy. That is, we'll remove the walls of the cyst using harmonic, and subsequently it is carefully placed in the endobag. The packing gauze is also placed in the endobag. Hemostasis is achieved and endobag is removed and cavity inspected again for any presence of any bile or cystobiliary communication. We wait for around 10 to 15 minutes post procedure so that if there is any bile or any suspicion of cystobiliary communication, it is detected on table and drain is placed. Post-operatively, this patient had no issues and was discharged on post-operative day 4. We continued with albendazole. And again, these are the cyst cavity, the hydrated cyst, daughter cyst, and the wall. These are various port positions that we had used, 2 in the mid-clavicular line on either side, and one 10 mm port was placed via the umbilicus. The residual cavity in this case was left open and we had just placed a drain. Other ways to manage this residual cavity is by simple closure or introflexion of the walls, flattening of the rim of the pericyst, capitonage, that is spiral suturing from the bottom of the cyst towards the periphery, or placement of omentum, that is the omentoplasty. Coming to the cystobiliary communication, most common complication of hydrated cyst is cystobiliary communication, which occurs in around 40 to 60% and causes 20% post-operative morbidity. These cystobiliary communications can be silent in around 80 to 90% and symptomatic in 3 to 10%. Those with symptomatic usually have a triad of biliary colic, jaundice, and urticaria. If a patient has this triad, it is usually a major communication and should be carefully looked during the surgery. Recurrent cholangitis and infected cysts are another problem with these cystobiliary communications. These communications can be terminal or tangential. Major communication is a one which is more than 5 millimeter, or a major is the one which is less than or equal to 5 millimeter. How to suspect a cystobiliary communication preoperatively? It is to patient's history of recurrent cholangitis, obstructive jaundice, biliary colic, or urticaria or allergies, which is seen in around 32% of the patients, or biochemical parameters like deranged liver function test, including bilirubin and alkaline phosphatase, raised leukocytes, and radiological suspicion, which includes dilated bile duct with or without presence of debris in it, seen in around 24% of patients, large cyst that is more than 7.5 centimeters cyst size has a specificity of around 73% and sensitivity of around 80%, presence of a centrally located cyst near the hilum. If there is a suspicion of cystobiliary communication, MRI, MRCP, or ERCP, or any direct cholangiogram can be done to delineate and detect the communication. Intraoperative predictors include aspiration of bilious content or bile soap gauze pieces. If it is so, then intraoperatively we can further do air leak test. Methylene blue can be injected into the gallbladder or common bile duct if it is open, and we can see for any leakage in the cavity, or an intraoperative ultrasound if it is available can help to detect the same. How to manage this cystobiliary communication? So for minor communications, we can do direct suturing with or without placement of patch, omental patch, or if the CBD is open, we can place a T-tube for drainage, or we can do internal drainage, that is transduodenal sphincteroplasty or endoscopic papillotomy. But the simple way is to do, if you have done direct suturing, and if the size of the communication is large enough and we don't have expertise, best way is to put an external drain and refer the patient to a center where it is available. Other than that, we can do reconstructions like pericystojejunostomy or liver resection, which is indicated in major communications and is rarely done. So my take-home message is laparoscopic management of hydrated cyst is being widely used currently, but patient selection is it needs to be stringent, and suspecting cystobiliary communication preoperatively, intraoperatively, as well as managing it reduces patients' post-operative morbidity. Thank you.
Thank you, Dr. Payal. Thank you, Dr. Payal, for a comprehensive talk. Mute करो अपना. Hello. So thank you, Dr. Payal. I think she has covered majority of the things on related to high cyst liver, and it is what we know till time is that it is endemic in India, and we have to we do find it very commonly in our OPDs. I think every 10th patient or 11th patient we operate is for hydrated cyst, for a benign disease of liver. And one important thing is that you should know how to figure out whether the hydrated cyst has a biliary communication or not. She beautifully enumerated the points that if the patient has had history of jaundice, or there is derangement of LFT, or on imaging there is a dilatation of intrahepatic biliary radicals, we should always suspect hydrated cyst and hydrated cyst communication with the bile duct. And if the cyst is more than 5 centimeters or centrally located, so it has high chances of communication. And in these cases, we should be very careful. We should get a MRCP done preoperatively and delineate the hydrated cyst communication. If there is communication which is noted, we should always go for ERCP prior to the surgery. And intraop, definitely there are various methods to find out if there is a communication. And if you don't find any communication, if the hydrated cyst is small, peripheral, and after evacuating the cyst, we find there is no biliary leak, bile leak, then we should not be very happy at the first time, but we should always wait. We should always decompress the abdomen if we are doing laparoscopically, because many times a pressure of 10 to 15 millimeters of mercury, they hide the smaller communications with the bile duct. So we should always wait for 10 minutes after decompressing the abdomen and re-inflate the abdomen to see if there is any bile leak or not. This is one of the methods to find out subtle biliary communications if there are any. And definitely, if there are peripheral leaks, they will we can get away with just placing a drain or taking one or two sutures. But if it is a central leak, we might have to convert or go for other procedures like T-tube drainage of the bile duct or maybe heparectomy as well at times. So if there are any, I don't find any questions in the chat box. If anybody wants to ask any question online, we are happy to answer.
Yeah, one question, sir. Pre of albendazole, how long you will use it, sir?
Please repeat your question.
Pre of albendazole, how
Yes.
long you will use it?
So what guidelines say is that minimum of uh, uh, seven, 72 hours, 72 hours of or 4 days to 5 days of albendazole. But what we prefer is we give 2 to 3 cycles of albendazole prior to the surgery, and it is 3 weeks and 1 or 2 weeks off, and then again for 3 weeks. Like this, we go for 2 or 3 cycles, and then we go ahead with the surgery.
Like open cases, is it possible to pack around the cyst, sir, to localize?
Yes, we have to. We should always pack around the cyst, whether it be open or laparoscopy. So
Okay.
laparoscopy, there is always a compromise on the amount of packing we
Yeah.
can do, because we
Yes.
use roller gauges while packing. While in open, we can always use mops soaked in betadine or 3% saline. So I'll suggest that if there is high chances of bile leak, biliary communication, you can use 3% saline. That because that will not obscure the biliary communication. But if you use betadine many times, the color of the betadine may confuse you with biliary leaks. So initially, my preference is to use 3% saline, and finally, when there is no communication, I do irrigate the cavity with 10% betadine.
Thank you, sir. Thank you.
So now we can move forward with our next presentation. We'll be moving to Dr. Yash. Dr. Yash Vadan Sinha is assistant professor again at surgical gastroenterology at ASRI place, and he will be talking on laparoscopic splenectomy. Though splenectomy can be done open lap both, but laparoscopic splenectomy is more cosmetic and more important for young chaps who require splenectomy, especially for hemolytic diseases. So over to Dr. Yash Sinha, who will be talking on laparoscopic splenectomy.
Good evening, everyone. Is my voice audible? Is my voice audible? Is my voice audible now?
It's audible.
Yeah.
Yeah, audible.
So I'll be talking about laparoscopic splenectomy. In the present era, the laparoscopic splenectomy has become the standard of care if feasible, as it offers minimal post-operative mobility and early recovery after surgery. So after many detailed lectures by my colleagues, I'll be keeping this talk very simple and stick to only the operative principles. So I have no conflict of interest. So starting with, we have a few main indications for splenectomy. So in the emergency setting, we have a high-grade splenic injury, either a grade 4 or grade 5, or splenic rupture. And for in the elective setting, we have multiple indications for offering splenectomy. So multiple hematological diseases such as ITP, hereditary spherocytosis, thalassemia, sickle cell disease. Among the neoplasm and cyst, lymphoma, leukemia, splenic abscesses, splenic cysts, all form an indication for laparoscopic splenectomy. A few of the rarer indications for offering splenectomy include vascular indications. The vascular indications include being splenic artery aneurysms or wandering spleen and left-sided portal hypertension. So we receive a number of patients with extrahepatic portal vein obstruction and non-cirrhotic portal fibrosis, for which we offer splenectomy as a mode of treatment. Now, how do we set up the OT? So they are basically we have two positions for the patient. So a number of surgeons prefer to operate in a left lateral position, but we in our hospital tend to operate in the supine posture, and we keep a kidney bridge. So we place a pillow just at the level of the kidney to elevate the spleen during surgery. The surgeon and the camera stand on the right side of the patient, and the second assistant stands on the left side of the patient. And for this surgery, we generally use 4 ports. So we have a 12 camera port, which is placed roughly in the midline, and a 5 port, which is placed in the epigastric region or slightly towards the right, followed by another port, which is placed on the mid-clavicular line. And we have the assistant port, which is placed as laterally as possible, preferentially along the mid-axillary line. Now, briefly going through the steps of the surgery, which we'll be discussing. So the surgery begins with the opening of the lesser sac, followed by division of gastrosplenic vessels. This includes the left gastroepiploic artery and the short gastric vessels. After this, we focus our attention to the splenic hilum dissection. The first step is to dissect the splenic artery, followed by dissection of the pancreatic tail and the splenic vein. And after the splenic hilum is divided, we divide the rest of the remaining attachments of the spleen, which mainly include the splenorenal ligaments and the phenylocolic ligaments. And following that, the specimen is placed in an endobag or a urobag, and this is removed either through a phalansteal incision, or we tend to morcellate the spleen either using forceps or using a morcellator. I've summarized, we have basically at our hospital standardized all the steps of laparoscopic splenectomy, and we tend to follow the same sequence, whatever the case may be. So again, as shown, we open the lesser sac, divide the left gastroepiploic and the short gastric vessels. Then we focus our attention on the splenic hilum. We take control of the splenic artery first. So normally the spleen is a very turgid organ, and to mobilize it or manipulate it is very difficult. So after we ligate the splenic artery, the spleen becomes very supple, and its manipulation and mobilization becomes very easy. Now there are different ways to tackle the splenic vessels and the splenic vein. So either we can use intracorporeal knotting or use large Liger clips or even vascular staplers. After the splenic hilum is divided, we divide all the remaining ligaments, which includes the splenocolic ligaments, the splenorenal ligaments, and the phrenicospinic ligaments. After that, the specimen is placed in an endobag and is removed. I'll be going through a short video of a laparoscopic splenectomy that we perform for a young patient with a splenic cyst. I'll be discussing the potential complications along the way, and we may discuss it at the end of the video. So the surgery begins with the opening up of the lesser omentum. So the assistant grabs one end of the lesser omentum and the surgeon grabs the other end, and we divide the lesser omentum, and we make a window in the lesser omentum. Follow that, we start progressing cranially. As we progress cranially, we tend to divide the left gastroepiploic vessel first. If it's a large vessel, we tend to divide it within clips, or sometimes if the vessels are small and harmonic is sufficient. Now we are taking down the short gastric vessels and moving towards the superior pole of the spleen. So after these vessels have been divided, we focus our attention to the splenic artery. Now the splenic artery is generally found at the upper border of the pancreas. So we tend to lift the peritoneum over the splenic artery and tend to dissect it circumferentially. This requires very careful and fine movements, as undue traction or rough movements may cause bleeding from the splenic artery. So after a window has been made below the splenic artery, it is a good practice to loop the splenic vessel. So we generally use either a silk tie or a sentinel loop to loop the splenic artery. So the looping of the splenic artery has multiple advantages. So it helps us to negotiate the artery both proximally and distally for sufficient length. After we have mobilized it for a sufficient end, we place hemolog clips. Now there are a number of methods to divide the splenic artery. So we generally use hemolog clips in our practice. So it is always a safe practice to apply 2 clips proximally. Now before dividing the splenic artery, we tend to lift up the splenic artery and mobilize it from the splenic vein. The next step is the dissection of the pancreatic tail. So the pancreatic tail injury is one of the most common causes of a pancreatic fistula following a splenectomy. So we tend to carefully dissect it off the splenic vein, avoiding any injury. So after the splenic hilum has been tackled, we make sure to free the inferior pole of the spleen. So we divide the splenocolic and the phenocolic attachments. A point here is to be that all the dissection needs to be very gentle. We should not force our instruments through any of the spaces that we see. And it is a good practice to have good harmonic harmonic available at your disposal for the surgery. Now, after all the attachments have been cleared off, we'll focus our attention to the splenic vein, and then we'll divide the splenic vein. The 2 things that we make sure are that the pancreatic tail is away from where we are going to ligate the spleen or the splenic vein or divide the splenic vein. For this case, we have used a vascular stapler for dividing the splenic vein. After the splenic vein has been divided, the spleen becomes relatively free, and then we divide off all the remaining attachments of the spleen. So we have some of the renal ligaments and the splenophrenic ligaments that are in place. So we use a harmonic source and divide the remaining ligaments. After the spleen has been completely freed of all the attachments, we create an endo-euro bag. So we take a euro bag and apply a purslin suture at its open end, and we introduce it into the abdomen, and we place the entire spleen into that euro bag. So there are a number of methods to extract the spleen. So if we want to extract the spleen in toto, we generally use a fancy incision and extract the spleen. The other method is that we widen the incision to allow the introduction of a larger forceps by which we modulate the spleen inside the bag and take it out in bits. Uh, so this is the entire procedure for a laparoscopic splenectomy. If you have any questions or queries regarding any operative tips or complication that you need to handle, I'm free for.
What's the maximum size you go for lap splenectomy, sir? Around 20 centimeters as usual.
Hello?
Hello.
Yes, sir. You're audible now.
Yeah. Regarding splenectomy, how do you manage that pre-op and post-op?
Speniculi, sir.
Yeah.
So normally it depends upon the indication for which you are performing the splenectomy. So if it's for a splenic rupture or a splenic trauma you're performing the splenectomy, you tend to leave the speniculi alone. But if you're performing a splenectomy for hematological diseases, be it sickle cell disease or thalassemia, or then we tend to remove all the speniculi. I mean, we remove the spleen and the speniculi. So it basically depends. And also it would depend upon how close the spiniculi are to the main vessels. So if you have a spiniculi which is sticking to your splenic vein or the splenic artery, you will tend to remove it. And if it's far away in the greater momentum, you may just leave it if it's not hindering your dissection.
Yeah. Division of splenic vessels, how far away you will go for from the hilum?
So normally, so first thing is like the splenic artery. So we generally tend to have a preoperative imaging. So we tend to know whether the splenic artery has a magistral pattern or a distributive pattern. So if we know that the splenic artery is dividing into its branches close to the hilum, we tend to just locate the upper border of the pancreas, and we tend to ligate the spleen at the upper border of the pancreas, because it tends to make a dissection very easy. In some cases, when we are forced to take the splenic artery close to the hilum, so it becomes a little tedious because we might have to ligate multiple branches. So in our practice, it is best to ligate the splenic artery where it is a single branch at the upper pole of the pancreas, and then we looping the splenic artery, we tend to dissect the splenic vein and the pancreatic tail, and then after the inferior pole of the spleen has been mobilized, we divide the splenic vein last. So that is how we try to follow routine in our.
Do you have any precautions in when you're handling NCPF?
To give an honest opinion, for NCPS, we have
It's not audible, sir. Hello.
Hello?
It's not audible, sir.
Just give me, I'll just check my. Hello?
Hello.
Is it audible now, sir?
Now it's audible, sir.
So basically now.
It's again not audible, sir.
Sorry, am I audible now?
Yeah, it's audible now, sir.
So for NCPF, we have done a few cases laparoscopically, but it depends. We choose our cases preoperatively. So we tend to choose only those cases where we see that the collaterals in the linear ligament are minimal. So if we see thick, large vascular collaterals in the ligament, we tend to do it as an open procedure. But if there are minimal collaterals there and it's a young patient, we tend to do it laparoscopically. So it all depends, how vascular those collaterals are in the region of your between your kidney and your spleen.
Yeah. Thank you. Very nice.
Does this answer your query?
Yeah. It's nice because that is a splenorenal ligament is critical for that.
Hello?
Yeah. Hello.
Hello.
Yeah.
I hope you got the answer well.
Yeah. It's nicely answered. Thank you.
Thank you. So, are there any questions regarding splenectomy? So, splenectomy overall is a straightforward procedure if the spleen is not too large, as in NCPF. Otherwise, for hemolytic diseases and all, laparoscopic splenectomy is a good option.
Good
And
option.
I think Dr. Yash covered each and every aspect of splenectomy very well. So, with this, we can move to our next topic, which will be covered by Dr. Kush Parekh, and he'll be talking on laparoscopic right hemicolectomy and how to proceed and what are the indications. And the same can be replicated in open procedures also. So, over to Dr. Kush for laparoscopic right hemicolectomy.
Good evening, everyone. Greetings from SGPGI. So I'll be describing the laparoscopic right hemicolectomy procedure. My talk will take you through the basic anatomy relevant to laparoscopic right hemicolectomy, the lymphatic drainage of the right colon, important for surgery, the details of the OR setup, patient positioning, and port placement, the various approaches required and described in literature for right-sided colectomy, and when to use what, the detailed procedure and steps through a video, and a few tips and tricks to avoid complications. So beginning with the anatomy, the right colon is developed from the post-arterial segment of the midgut, and hence it derives majority of its supply from the right side of the superior mesenteric artery through the ileocolic, middle colic arteries, and occasionally the right colic artery if present. The majority of the venous drainage is through the superior mesenteric vein via the ileocolic vein and the middle colic vein, and occasionally through the right colic vein if it is present. And the right image shows the procedure that I'll be describing in detail today: right hemicolectomy and right extended hemicolectomy. For right hemicolectomy, the line of transection follows the right branch of the middle colic pedicle, and for right extended hemicolectomy, the line of transection is along the middle colic pedicle. So importance of the arterial supply, the predominant arterial supply of the right colon is the ileocolic artery, which is present in almost 100% of the cases. Second is the middle colic artery, which originates from the superior mesenteric artery below the pancreas, which is seen in 94% of individuals. And the right colic artery, which is encountered only in 60% of the patients. 40% of the times, the right colic artery is absent. What makes it important to study the preoperative CT scan is the course of the ileocolic artery and the right colic artery in relation to the superior mesenteric vein. The artery might cross anterior to the superior mesenteric vein, and occasionally it might cross posterior to the superior mesenteric vein. And this becomes very imperative from minimally invasive surgery point of view, because we do not have as good haptic feedback as open surgery. So we cannot rely on pulsations of the artery or visualization of pulsations of the artery during surgery, especially in morbidly obese patients or in patients who have very thick visceral pad of fat where pulsations might not be seen. So accurate anatomy mapping in preoperative CT, depending on the course of the artery, is extremely crucial for minimally invasive surgery. Coming to the venous drainage is through the ileocolic vein and the middle colic vein predominantly, and there might be two right colic veins. One is the main right colic vein, which drains into the superior mesenteric vein or the gastrocolic trunk of Henle, and the accessory right colic vein, which usually drains into the gastrocolic trunk of Henle, as seen in the first picture. I'll just show it with a pointer. So this is the gastrocolic trunk of Henle, which is formed by the right gastroepiploic vein and the superior pancreaticoduodenal vein. And the accessory right colic vein comes from the hepatic flexure and drains proximally into the GCT. So what makes it important to study the anatomy of the GCT is the variations that are possible and described in literature. Usually, the variations are described depending on the number of colic veins which drain into the GCT. Type A anatomy is when no colic veins drain into the GCT. The GCT is formed by the gastroepiploic vein and the pancreaticoduodenal vein. And this is seen only in 7% of the individuals. So in majority, either one or two colic veins drain into the gastrocolic trunk of Henle. Type B is the second most common type, where the gastroepiploic vein, the pancreaticoduodenal vein, and the accessory right colic vein form the GCT. This is the most common variety which you'll encounter in 70% individuals. Type C is when the main right colic vein, in addition to the accessory right colic vein, drain into the GCT before the GCT drains into the SMV. This is seen in 20% of the individuals. And the last variety, type D, is when the middle colic vein, in addition to the previous two veins which I mentioned, drains into the GCT. This is seen only in 2% individuals, meaning 98% of the times the middle colic vein drains into the superior mesenteric vein. This is important because we'll be taking all these vessels at the root to achieve a CME with CVL, that is complete mesocolic excision, along with a central vascular ligation at their root from the SMV and the SMA for the veins and the artery respectively. So when we perform a D2 lymphadenectomy, these vessels are normally taken at the root of the major vessels. And when we go on to perform a D3 lymphadenectomy, we are supposed to clear the lymph nodes at the SMV and the SMA. That is this bed, which extends from the gastrocolic trunk of Henle to the lowermost extent, which is the ileocolic pedicle. And this trunk is known as the surgical trunk of Gillot. Coming to the lymphatic drainage, the lymphatic drainage of the colon has been described in anatomy into 4 groups of lymph nodes. One is the epicolic, which are bang opposite to the colonic wall on the mesocolic side. Next station is the intermediate paracolic nodes, which are along the marginal artery of Drummond. The next station is the intermediate nodes, which are along the right colic, the ileocolic, and the middle colic artery. And the last station is the principal nodes, which are dissected during the D3 lymphadenectomy along the major vessels, that is the SMV and the SMA. Now, the Japanese Society of Colorectal Surgeons have numbered these stations to describe the lymphadenectomy better and the clearance of the stations better for oncological clearance. So the ileocolic pedicle has been numbered as station 20, and depending on the location of the group of lymph nodes from epicolic to principal nodes, they've been named as 1, 2, and 3. Similarly, the right colic pedicle has been named as station 21, and depending on the location of the nodes, it's 1, 2, or 3. And the middle colic station has been numbered as 22. So these are our lymph node group of interest for this procedure which I'm describing. So why is it important to study the lymph nodes and the lymphatic drainage? Because depending on the tumor location, the percentage involvement of the lymph node changes. If the tumor is located in the cecum, around 40 to 50% of the times, the ileocolic lymph nodes are involved. Only 4 to 5% of the times, the right colic lymph nodes, if the right colic artery is present, are involved. And usually, the involvement of the middle colic lymph nodes is in the tune of 0%. So, performing a formal right hemicolectomy and sparing the middle colic artery pedicle is an appropriate procedure for this kind of a tumor. As the tumor ascends up into the ascending colon and the hepatic flexure on the right side, you see the percentage involvement of the lymph nodes serially increases, and hence the procedure transitions from right hemicolectomy to right extended hemicolectomy as per the location of the tumor. So when we talk about minimally invasive right hemicolectomy, it can be performed either totally laparoscopically, where the colectomy is performed using laparoscopic platform and the reconstruction is done intracorporeally using a stapler or very rarely hand-sewn anastomosis. Second is laparoscopic assisted procedure, where the resection is done laparoscopically, but the reconstruction is done through a midline incision extracorporeally and the specimen is retrieved from the same incision. And the third type is hand-assisted laparoscopic colectomy, where a hand port is inserted, and the surgeon actually inserts one hand of his to retract the colon, and the resection is performed using energy devices and laparoscopic instruments. That is called as hand-assisted colectomy. So coming to the OR setup, this is our OR setup, how we routinely perform a right hemicolectomy. The surgeon stands on the left side of the patient and occasionally between the two legs, depending on the phase of dissection. We have two monitors, one for the main surgeon and one for the assistant standing on the opposite side. This is the scrub nurse on the right side. The second assistant is usually showing the camera, and the first assistant is usually showing the camera, and the second assistant helps in retraction using laparoscopic instruments. The patient is usually strapped well, given a leg split position with leggings, stirrups, which are well padded using cotton pads, because this is at most to prevent injury to the nerves during splitting the legs. And the patient should be strapped, otherwise the extremes of position in which the table tilts from Trendelenburg to reverse Trendelenburg can lead to slipping of the patient and undue injuries during the procedure. So hence, your patient must be well padded and secured for a good surgery. Coming to the port placement, the procedure can be done using 4 ports, where the camera port is docked in the center infraumbilically. There are 2 working ports for the main surgeon, left-sided 12 mm port for gauze insertion, needle insertion, and working instruments. The right-sided port for energy devices, which is a 5 mm port that is sufficient, and a 5 mm retraction port in the right iliac fossa. This can be increased to 5 ports, where an additional 12 mm port is inserted in the suprapubic region. So variation between 4 port and 5 port can be changed depending on the patient body habitus, the space that is created after pneumoperitoneum is attained, the amount of visceral fat, the bulk of the tumor, and the retraction that is possible after mobilizing the colon. So depending on all these factors, you can decide whether you want to put an additional port or not. So coming to the approaches, so right hemicolectomy can be done in 2 ways, where you can target the vessel first, that is the vessel first technique, or you mobilize the colon first and then target the vessels, that is the colon mobilization first approach. In colon mobilization first approach, again, we've got 3 varieties, where you begin the mobilization colon from top to bottom, that is cranial end. You open the lesser sac, mobilize the colon from above, and then reach caudally to the ilial end, that is cranial to caudal approach. If you flip it around, do the caudal dissection first and move cranially, that is the caudal to cranial approach. And lateral to medial approach is the classic approach which is followed in open surgery, which is rarely used in laparoscopic surgery, because mobilizing the colon from the lateral parietal wall actually laxes the mesocolon fat, and hence vessel dissection becomes difficult subsequently. So colon mobilization from the lateral wall is done in the end during laparoscopic surgery. In vessel
Which
first
approach
approach,
is
you target the vessels medially,
Yeah.
dissect them along the SMV and SMA, ligate them on the root, and then dissect and mobilize the colon subsequently. So coming to our first approach, caudal to cranial, and subsequently I'll be describing the second approach, that is cranial to caudal. Both approaches are used in a setup depending on the tumor variety, the tumor bulk, the tumor stage, and the patient body habitus. Play this. Yeah. So in caudal to cranial approach, you retract and make the ilial mesentery taut and start mobilizing along the white line of taut, where you can see over here that there is a good plane between the ilial mesentery and the posterior retroperitoneum. Here what we are cutting is the loose areolar tissue, which is the Talt's fusion fascia between the mesocolon and the retroperitoneum posteriorly. The left hand retraction is of utmost importance, because that is what is going to open your plane up. It is not the energy device that is doing the dissection, but the main role is being played by your left hand. So retracting the mesocolon above is of extreme importance. Once you dissect anterior to the duodenum, you come cranially and open the window, and then you can see the gallbladder there, and there we place a gauze piece. Now we create a window in the ilial mesentery, and start dividing the ileal mesentery along the ileocolic pedicle. On the right side here, you can see is the jejunal trunk, and on the left side is the ileocolic pedicle. Here we are dividing the fat in between these two vessels so that we can reach the caudal end of the SMV. Use your energy source very carefully. The tip of the harmonic should not burn thick chunks of tissue. It should just burn very small chunks of tissue to avoid any undue hemorrhage. Here we are ligating the ileocolic pedicle using hemolock clips. And then we are moving along the SMV. Here the SMV, the anterior surface of the SMV has been cleared of the middle colic pedicle. And then we move cranially. This is the gastrocolic trunk of Henle and the accessory colic vein, which has been divided. And now we move cranially further into the lesser sac and dividing the colonic attachments by dividing the gastrocolic omentum. Here we can see the gauze piece which we had previously placed after visualizing the gallbladder, and the colonic mobilization is completed over here. The lateral attachments, as I mentioned earlier, are taken down in the end so that our mesocolon is open like a sheet of paper and we can dissect the vessels easily in the initial phase of dissection. So this completes the caudal to cranial approach. Now I move on to the cranial to caudal approach. So here we are opening the lesser sac. The assistant retracts the stomach above and the left hand pulls down the gastrocolic omentum, and then you can nicely enter the lesser sac. Then you move closer to the right gastroepiploic vein. By dissecting and tracing the right gastroepiploic vein below, you can reach the gastrocolic trunk of Henle. That is important because our accessory right colic vein inserts right into the GCT, and we are supposed to ligate it at the root of GCT for adequate lymph node clearance along these venous channels. So this is our right gastroepiploic vein. By careful blunt dissection and sharp dissection and minimal use of energy source, by burning short chunks of tissue, you can avoid avulsing these veins, because as a group, these veins are called as veins of danger. Once you bear the fat around these veins, they are prone to rupture and can bleed torrentially because they directly drain into the SMV. So whatever bleeding you encounter over here is going to be directly from the SMV. So please be careful, and please be careful while using harmonic over here as well, because the hot shears of the harmonic can cause a big hole into the vein, and again they can bleed torrentially. So now we move along the inferior edge of the pancreas. And here you see we are ligating the accessory right colic vein, which is inserting into the gastrocolic trunk of Henle. Subsequently, we dissect the fusion fascia between the pancreas and the mesocolon, which is the fusion fascia of Reddit, and we define the anterior surface of the superior mesenteric vein, which is right in our vision. And this is the right colic vein. Because of the bulk of the tumor, the anatomy is slightly distorted, but the middle colic vein is inserting towards the left of the superior mesenteric vein, which we are ligating over here. Sorry, the right colic vein, not the middle colic vein. Now we pull the mesocolon and reflect it up, and we define our middle colic pedicle. And then we clear the lymph nodes along the root of the middle colic vessel. Since this was a bulky tumor, we decided to perform a D3 lymphadenectomy, and hence we are clearing all the lymph nodes at the base of the middle colic vessel. From here, we start moving caudally along the anterior surface of the superior mesenteric vein and the superior mesenteric artery. This dissection in the initial phase for the beginners should be performed using a Maryland and harmonic energy source, which should be done carefully, because in case of bulky lymph nodes, they've got direct venous tributaries from the vein and direct feeders from the artery. And if you dissect rashly with a hook, it can lead to torrential hemorrhage. At the caudal end, we ligate the ileocolic artery, as you just saw, and now we are dissecting the tissue at the lateral edge of the superior mesenteric vein to define the ileocolic vein. A window is created and subsequently Hem-o-lok clips are applied at the root of the ileocolic vein, just where it is draining into the superior mesenteric vein. Again, if you leave too much thick tissue around the vein, the clips may not be adequately applied. So don't be in a hurry to just divide the vessel. Use metal clips. They are very good for veins, but not good for arteries. Arteries can dissect with metal clips. So Hem-o-lok clips are preferred for arteries, but for veins, metal clips are as good as Hem-o-lok clips. Now we complete the mobilization of the colon laterally, but since you see the tumor is too bulky and attached to the lateral parietal wall, the mobilization towards the lateral wall is difficult in the hepatic flexure area. The tissue is not yielding that easily as it was in the first case. So we complete the dissection cranially and leave that last bit of the tumor attachment towards the lateral parietal wall for the end. Now we divide the terminal ileal mesentery and divide the ileum by firing a stapler. You can use a blue stapler, but now purple cartridges are available. So purple cartridges, which is the tri-staple technology, can also be used if it is available in your setup. Otherwise, blue cartridge is as good as a purple cartridge. You can use them. This is the last bit of the attachment of the cecum in the right iliac fossa, which is being divided. This plane is supple and can be easily divided using harmonic energy source. Sorry for the poor vision there. And as we move cranially, we can see that the tumor was bulky and it is attached to the lateral parietal wall. So your left hand has to retract the colon medially, and your left hand has to do a lot of work. And here we decided to take a sleeve of peritoneum and the parietal wall along with the tumor, since it was a T4B tumor infiltrating into the lateral parietal wall. So this part of the dissection was done in the end. And lastly, we mobilize the hepatic flexure by dividing the peritoneal attachments there. Few small tips: keep the active blade of the harmonic shears above. Don't let it touch down, because all colorectal surgeons are guardians of the retroperitoneum, and all retroperitoneal structures should remain in the retroperitoneum. Now we proceed with intracorporeal reconstruction. We create an enterotomy in the terminal ileum. It should be a very small enterotomy. Don't make an overzealous big enterotomy, which will take too much time to suture, because a small opening is just enough for the stapler to go inside. You fire the stapler. That is the small enterotomy which you see. We take interrupted vicral sutures at the stapled ends and then suture the remaining enterotomy using a V-lock continuous suture. These are barbed sutures, and they are just good as interrupted suturing as you do with any vicral suture. So if it's available, you can use this. Otherwise, interrupted vicral suturing is as good as using barbed sutures. And we place a drain in the hemicolectomy bed over here. So this is the final outcome, because we retrieve the specimen by extending the umbilical port. Now, lastly, before I conclude my talk, I'll just mention a few tips and tricks which must be followed to prevent injury to the ureter, prevent bleeding, and some tips and tricks for attaining hemostasis if you encounter bleeding during vessel ligation and colon mobilization. And lastly, duodenal injury. These three are key complications which one can encounter during a right hemicolectomy. So regarding ureter identification and preservation, identify the ureter and visualize the ureter is of utmost importance to prevent injury. If it is under vision, you're very less likely to injure the ureter. In difficult cases like a T4B tumor, which is infiltrating towards the retroperitoneum, a growth which is perforated locally, caused an abscess, there is too much local inflammation. In morbidly obese patients where there is just too much retroperitoneal fat where you cannot visualize retroperitoneal structures, and in reoperative surgeries, you can use assisted techniques like ureteral catheters, which can be normal catheterization, which you can feel with an haptic feedback that you get with your laparoscopic instruments. And recently now there are new fluorescent stents which are available, which glow actually inside the abdomen, and the ureter tells you that, oh, I'm in this position and you got to be careful while dissecting near me. And preoperatively, you can inject indocyanine green cystoscopically into the ureters, and the ureters glow up, throwing the green light inside the abdomen, and you know where they are lying, and you can dissect carefully next to the ureters. Next is bleeding and hemostasis. Bleeding can be encountered during 3 phases. One is during colon mobilization from tiny retroperitoneal vessels or the gonadal vein if you are in the wrong plane. During the cranial phase, while dissecting near the gastrocolic trunk or the middle colic vessels, and during the caudal phase from the ileocolic vessels or the right colic vessels, and the SMV and the SMA. So few tips: use energy devices carefully, as I've been stressing upon during my presentation. Beware of the hot tip of the shears and any insulation breach which is present in your hook or laparoscopic instruments. Clip securely before division. Don't be in a rush to divide vessels. Clip securely. If you think you've not clipped securely, place additional clips and then divide, and mobilize the vessel adequately before clipping. Do not seal vessels in tension. If you stretch too much and then you seal your vessels, they're about to give way, and the sealing action is not going to be adequate from your energy source. They are bound to bleed. And seal smaller tissue chunks. Don't seal larger chunks so that your energy source, does not apply adequate sealing action to the vessel. So seal smaller chunks of tissue. In case of bleeding, compress using a gauze, prepare with your suction, tell your staff whatever material you are required, whatever material is required to attain hemostasis, and then go in, clean your camera, focus at the site of bleeding, suck that area adequately, and then do a targeted hemostasis rather than, just buzzing around that area where it is bleeding blindly. That causes more injury. And conversion is not defeat, like Dr. Rahul also said. Always patient safety is first, so don't be ashamed to convert in case of difficulty. Lastly, duodenum and bowel injury can occur during 2 phases. One is during attaining access, during the Veress needle insertion or the trocar insertion. So the prevention technique is, once you enter the abdomen, just inspect the area below the port from where you've entered, or below the Veress needle from where you've taken entry, and just inspect the peritoneal cavity and the bowel underneath. And the second point of injury is during dissection. Either it can be a thermal injury or can be a retraction injury while giving traction. So simple points is, if there is an injury, take sutures rather than, saying it's just a serosal tear, ignoring it, and regretting later in the post-op where patient might have a leak. Dab the raw area with a clean white gauze and look for active bile staining, and take proper suture bites in that area rather than taking blind sutures over the raw surface. And in the end of the procedure, position your drain well, because the drain is going to help you in post-operative period if you face complications. So that's my talk. Thank you. And that's our team from the department. I'm happy to take questions.
Very nice presentation. Yeah. When you will prefer the vessel first or colon first technique?
So, sir, vessel first technique can be used in bulky tumors, like the second case where you saw. If the tumor is too bulky, infiltrating the psoas muscle posteriorly, infiltrating the retroperitoneum, you can very well comfortably, ligate your vessels first and subsequently start mobilizing the colon from medial to lateral. Alternatively, you can do the cranial to caudal approach as well, because the lesser sac is going to be a free cavity. Your tumor will be located towards the right parietes or the right retroperitoneal side.
Oh.
So mobilize the colon medially, take the vessels early, and then, start dissecting towards the lateral wall. That is much helpful in these cases.
Yeah. Thank you, Parikh.
Thank you.
So thank you, Dr. Kush. A beautiful demonstration of laparoscopic technique, how to handle bowel and do a uh, uh, um, good colectomy. And I want to stress that he showed all kinds of colectomy D2 and D3. It is important to go for R0 resection. That is why all these things were stressed upon. So if you are doing a colectomy for malignancy, then definitely you should take care of all the nodes. But if we are doing a colectomy for a benign disease, then we can always stay away from the major vessels and we can go close to the colon. But when we are going for laparoscopy, it is important to take vascular control first so that it avoids bleeding and it eases the procedure throughout. So with this, we come to end with all our presentations. If there are any questions, still we can answer. So
Dr. Rahul, like as of now, there are no questions in the chat box here or in the YouTube. But people keep again and they view many times, and if any question is there, once they post, I will get back to your team. And from ASRI, I thank Dr. Rahul, additional professor, for taking such an effort for this wonderful discussion on different surgical gastro procedures, and his entire team.
thank you, sir. Thank you for the opportunity, first of all. And I thank my team because without them, this would not have been possible. And there were some technical glitches, sorry for that. But we have covered almost majority of the general procedures in GI surgery. We have more to discuss, but for beginners, I think this is good enough introduction for laparoscopic techniques. So thank you and goodbye for the day.
Yeah, one question, sir. One question.
Yes, please.
One question, sir. For a beginners to go for an advanced procedures, what are your suggestions?
So for advanced procedures, my suggestions are like if you're going for a say laparoscopic right hemiclectomy, which is one of the um, easier procedures, but will be considered as an advanced procedure. Do the dissection slowly, go for small bites, take control of the vessels with care, and you can always do a laparoscopic assisted techniques to start with. Like you do the resection part laparoscopically, but when you have to reconstruct, you can take out the specimen with a small incision and do the reconstruction outside. So to begin with, you can always do it in steps. Do dissection first and reconstruction later on. Second thing is you should always use your energy devices with care because they are useful but very dangerous instruments. And do handle the tissue with appropriate instruments. If you have to catch hold of the bowel or the colon, do use graspers rather than uh, serrated instruments. And uh, always dissect before you divide.
Yeah. Thank you, sir. Congratulations to the whole team. Well done, sir.
Thank you, Dr. Shankar.
Thank you, Dr. Rahul, again. And
thank you, sir. Thank you so much.
Thank you. So we go to the next session, which is on how to choose a super specialty branch after post graduation. To be rapporteurs for this session, I invite Dr. Rajni Kumari Shah and Dr. Mahalashmi. Dr. Rajni, over to you too.
Thank you, sir, for providing me this opportunity. For this session, which is of great importance to all the postgraduates, it is an extremely important thing so that the person who has already done a super specialty course in an branch which is not known to everybody, Dr. Mithun Ram sir, he delivers a talk on consideration in choosing super specialty branch. Over to you, sir.
Thank you, Dr. Rajni, for that kind introduction. I hope I'm audible.
Yes, Mithun, you are audible and you are visible as well.
Yes, now I am, let me just share my screen. Yeah, I hope my slides are also visible and we're good to go.
Yeah, the slides are visible and you are good to go.
Yes, thank you so much. So, before I begin, first of all, let me thank Dr. Sabaratnam and the entire team behind the ASRICon 2025 for giving me this opportunity. Now, when sir told me that I will have to be speaking on this topic, the first thing that came to my mind was this was something that was unique. Of course, I am an endocrine surgeon, so this kind of, maybe I should call this as an offbeat topic for an endocrine and breast surgeon per se, but this is something that I am passionate about, which is surgical education and postgraduate training. So I kind of gladly took up this task. So in the next 30 minutes, the title of my talk is basically how to choose your surgical path. The primary audience that this is intended for is the postgraduate students who are either embarking on their postgraduate journey or have already finished their postgraduate exams, are working as a senior resident or as a faculty member in a general surgical unit, and looking ahead as to what to do next. And also for some practitioners who have already been in general surgery for some time and are contemplating whether they should take the step further or should they stay back as general surgeons. So to be very honest, this is a topic that has been very close to my heart. This has been a conundrum, a dilemma which I myself have gone through and have uh, dealt with these various dilemmas and choices. So I think this is a kind of presentation that is going to be giving you a little bit of my experience as well as laying out the facts in front of you. So before I begin, let me give you some disclaimers. This is going to be only an overview of the different choices after basic surgical training. So by no stretch of imagination can I be making this very extensive. So this is going to be just an overview. I'm going to be touching upon certain aspects of choosing a specialty after basic surgical training. Most important thing, I cannot decode anybody's dilemma. I cannot make life choices for you in the limited time slot of 30 minutes. So this is something all of you are going to have to carry your own cross. You're going to have to make these decisions yourself. I'm just going to give you an overview. Very, very important thing, these opinions are purely mine. Any resemblance to any individual, any specialty per se is purely coincidental. So please take the positive points out of this presentation. And of course, me being an endocrine and breast surgeon, I will tend to use some examples from my own personal journey and my own specialty. So apologies for that. And of course, very important thing, the next 30 minutes, rather than helping you make up your mind, I would rather like you to open your mind to make yourself open to making any choice that is possible and how you're going to decide that. So let's uh, go further and let's look at what we have in our presentation. So conflict of interest, before we proceed further, first thing, this is a conference of rural surgeons of India, and I'm going to be slightly I'm going to be presenting an antithesis to it, which is I'm going to be talking about super specialization. Over the last few days, we've looked at very different specialties that exist in our country, right from basic stuff to high-end stuff. We've looked at the entire spectrum. So let me try and put that into perspective of this rural surgeons conference. And I must say, definitely, I am currently a specialist, but I've always, general surgery has been first love, and I've always been a generalist at heart. So that is also something I myself have a conflict of interest when I made this presentation. So let's go on. So the more than answers that we are going to be giving, I'm going to help you ask the right questions. So here are a few questions that we will be tackling. The first thing is, why should you specialize? So should you stay as a general surgeon? Should you really go into a super specialty? That is something that you need to consider. Another important thing, how do you specialize? What kind of modalities or what kind of opportunities do you have for specialization? What should you consider when you choose? I think this is the crux of my presentation, which is what are the factors and considerations you need to have when you want to put down your choice as a specialty of training. And of course, very important, when should you specialize? So these are a few of the questions that we will be looking at as we go along this presentation. So let me address the elephant in the room. The first question is, why should I specialize? Or in other words, should I specialize at all? I am sure that anybody and everybody who has spent some time in general surgery, maybe not the current generation, if I can say that, from the previous generation who spent some time in general surgery has always had this thought process cross through your mind. Should you specialize or should you stay back in general surgery? So just to put things into perspective, our current medical training pyramid is basically like most of our fathers. As you grow old, the more narrower you become, narrower your thought process becomes. So currently, as per whatever data we have, about 140,000 MBBS seats that are available, percolating down to around 5,000 MS general surgery postgraduate seats for training, and finally about 2020 seats that are available for MCH. So you can see the pyramid going down narrower and narrower. And to be very honest, this middle block of 5,000 odd general surgeons are what probably is going to serve the community in a better way, if I was to say so, rather than a super specialist. But we need to consider this in perspective of what does specialization give us versus what does being a generalist provide us with. So if you look at super specialization is necessary, definitely super specialization has a lot of good things. One thing is you are entirely focused in training, learning, and dealing with a particular organ system. So that makes you a true specialist of a particular organ system, and you are able to get an in-depth understanding of the diseases. Now, let's take breast, for example. From my own specialty, you're able to have an in-depth understanding of both benign as well as malignant spectrum of diseases. It gives a deeper perspective when you're dealing with patients and solving their clinical problems. You're able to have a purview of advanced clinical knowledge. You're able to manage patients better with the latest drugs. You have up-to-date surgical skills. And a very important thing is, because you deal with a particular organ system or a particular organ, you're able to have an up-to-date knowledge of the recent advances, the technology that is available, minimal access techniques, non-operative surgeries, and of course, the up-to-date information on the latest clinical trials, latest drugs that are available. And all these factors are definitely helpful in giving a comprehensive, evidence-based clinical care to our patients. And eventually these are going to result in better clinical outcomes. This is something that time and again there are innumerable amount of studies that are able to give us that a specialist who practices surgery in a particular organ system is able to give a better clinical outcome in terms of lesser complications as well as better patient satisfaction. So that is something that we cannot contest with. Now let's look also at the other side of the coin. So it's important that we look at that. So what does super specialization miss out? So one thing is definitely it's missing out on what's common. So an inguinal hernia, a basic appendicectomy, benign or a malignant breast lump, total thyroidectomy. These are things that in the yesteryears is what a general surgeon would typically consider as bread and butter. So super specializations, when a super specialist does that, they may tend to miss out some common diseases. And of course, it does have a higher cost implication for the surgeon as well, in terms of training, equipment, etc., as well as for the patient, because they'll have to have a referral system. And this referral system itself is a very tedious process. So you go to a general surgeon or a GP who refers to a general surgeon, and then the general surgeon refers to a super specialist. So it's kind of a little bit of running around the countryside just to reach a diagnosis and a management. And of course, sometimes we do tend to move away from core clinical skills, clinical examination, basic clinical acumen, tend to rely a bit more on advanced investigations rather than basic investigations. And of course, it definitely there is a different doctor-patient rapport that exists when you compare a general surgeon as compared to a specialist. And definitely the doctor-doctor relationship, especially between surgical specialties that do have an overlap or a surgical and medical specialties that have an overlap, it kind of causes a fracture within our medical fraternity. So these are some of the points that are against super specialization and rather to stay as a general surgeon. So the next question is, when should I specialize? Now, it's a very important thing as to when should somebody consider specialization. So is it now or is it never? Now, we are spending almost a decade in training when it comes to completing a super specialization degree. But remember, now we are in the era where should we consider hard work, or are we going to reach our target easily, especially in the NEET era where the competition has gone up in terms of a national eligibility exam? Another important thing to consider, does prior surgical work experience make a difference? So should you stay a general surgeon and then become a super specialist, or should you just finish your general surgery and straight away go to super specialization? There are some specialties which are based strongly in general surgery. For example, endocrine surgery, pediatric, GI, surgical oncology, head and neck. These are all very strongly based in general surgery. So probably your general surgical experience might make some better sense here. Some specialties, specific skill set, for example, neurosurgery, cardiothoracic, vascular, urology, especially endourology, minimal access or robotic. All this requires a specific skill set which may not really rely on a strong general surgical background. And my personal experience was I spent some time as a post MBBS person also in endocrine surgery, then went in for general surgical training. 3 years I worked in general surgery as a faculty. I worked for a year in corporate, and then subsequently I decided to do an MCH. And this significantly enhanced my knowledge, my skill, and my confidence, both during my broad specialty as well as super specialty training. So this is something that you need to consider whether to do hard work or smart work. This is something that I'm just opening your mind to. So it all depends on a personal choice. So it depends on what kind of specialty you're looking at. The specialties with a strong general surgical base, it might be worthwhile to spend some time in general surgery before moving on to super specialization. So now the next question is, how do I specialize? So there are two things that we must understand. There's something known as sub-specialization, and on the other hand, there's something known as super specialization. So when we talk about super specialization, essentially these are the different modalities of super specialization that we have in our country. Now, catering to Rural Surgeon Association, I'm not going to be talking about going abroad, brain drain, or training abroad. I'm purely talking about training in our country. So we have an MCH, Doctorate of National Board, long-term fellowships, or short-term fellowships, or observerships. Now they vary depending on a lot of factors. So MCH DNB, a longer duration of 3 years, whereas a PDCC or a fellowship maybe 1 to 2 years. You can even do a short-term fellowship which is just for 3 months, or maybe an observership for just under a month. And you must remember that MCH DNB have the advantage of being NMC recognized courses, whereas the fellowships and observerships are more institutionally recognized. And of course, the institutional recognized fellowships are easier to get in either through an exam or interview, whereas MCH and DNB is through NEET SS. Now, the type of institution mostly in an in MCH is a government or a private institution, whereas in a DNB you may have to be training eventually in a corporate hospital or a private hospital or a mission hospital, where your operating chances may be a little bit curtailed or maybe more under supervision. Whereas fellowships are usually in the government or more in the private setup. Now, when it comes to the training aspects, I've looked at three things: academics, clinical training or clinical skills, and research. So academics definitely in an MCH and a DNB program is better than fellowships. Academics in an MCH program is more structured, good clinical training with good clinical volumes, and of course a focus on research and doing a thesis and publications. DNB academics are sort of variable, but definitely you have a good clinical volume and a good clinical caseload, and research, depending on your center, may be variable. Now, academics and research take a little bit of a backseat when you do a fellowship. Again, depending if you're doing a PDCC from a central institute like SGPJMS, then definitely academics and research are on par with an MCH or a DNB. But definitely clinical training is very good in a long-term fellowship. Now, if you are already having a good basic surgical training, you want to learn a particular specialized skill. Let us say you want to learn laparoscopy, you want to learn robotic, or you want to learn one special skill, then a short-term fellowship would suffice, especially if you already have a practice that is running. So focus skill training, not much focus on academics and hardly any research, because short-term fellowships and observerships are unfortunately too short to embark on any research program. So this is just a snapshot of what are the different programs and what they give you and what they don't. So again, this is something that you have to decide depending on what your basic surgical training is, what kind of practice you're already doing, and what you aim to gain out of your training program. Of course, most of us are looking at an MCH DNB program because we want a NMC recognized degree. This is what I also looked at when I did consider PDCC and short-term fellowships, but definitely the NMC recognition and of course structured academics and a good structured program was why I chose to do MCH rather than go for a PDCC or a fellowship. Now there are so many different, there are 14 different specialties. This is from the NEET brochure for an MS general surgery postgraduate. Apart from that, MS ENT, MS orthopedics, trauma surgery, MS OG, so many different options that are available. And this actually creates a lot of confusion, and that's probably why I'm giving this talk today. So now let me come to the crux of my presentation as to what should I consider when I'm choosing a specialty. So a lot of factors. If you look at data, I tried looking for some studies. There is, interestingly, this is probably an idea we can do as a project. Maybe ASRI can take up this as a project, as to look at what are the factors that Indian postgraduate surgical residents consider when they want to choose a super specialty. There are only Western literature, especially from the UK. So a lot of different factors, as you can see in this picture, that decide what you're going to do in the future and why you want to do it. So a few aspects I just want to highlight on. One is definitely what is your own personal aptitude, your personality, what kind of surgical personality you have. Prior experience definitely makes impact. It may be a good experience, a bad, or even an ugly experience. So that may either make you want to take a specialty, or you might decide that these are the specialties I don't want to do. Mentorship, having a good mentor, very important. Work-life balance. Vitamin M, which is basically money. So that's something you definitely have to consider. Even though whatever we say about service, we definitely have to consider the monetary aspect of things. Future career growth, where one is going to settle. What is the competition like from our medical brethren, and of course our other surgical specialties, and of course what is your long-term vision and what do you see in yourself as a surgeon from 10, 15, 20, 25 years from now. So let me look at each of them. I'm going to break it down to discuss. So in terms of aptitude and personality, aptitude is basically two things when you talk about as a surgeon. So either a technical aptitude or a non-technical aptitude. You have your visuospatial orientation, your dexterity, cognitive skills, communication, interpersonal skill, psychological traits, your perception, your ability to counsel patients. So a lot of these things play a role in shaping a surgeon. They're very important in bringing out your surgical performance. So the natural ability or competence to do this kind of technical and non-technical things is what gives you a good aptitude to be a surgeon. And there are various factors. So either you may like intricate, hands-on, very fine work. For example, microvascular or free flaps. Then you might want to go into neurosurgery. You might want to go into plastic surgery. Or you might like broader, more cerebral work. You'd like to work with your hands more, so more gross stuff. So you might want to do GI, surgical oncology. Sometimes you can have best of both worlds, like endocrine surgery. I'm happy to do both fine work with thyroidectomies as well as do breast oncoplasty, and of course we also have our own share of minimal access surgeries. So it depends on what you want to take from that specialty in terms of your dexterity and your hands-on work. Open versus minimal access. very important thing, which specialty gives you more of minimal access. Some people are more interested in endoscopic, so they tend to take urology, gastrosurgery, more into open work than surgical oncology. Of course, minimal access has come in a big way currently. Are you interested in being a surgeon completely, or do you want to blend a bit of medicine, bit of research, medical background, non-operative techniques? So this is something that helped me take up endocrine surgery as specialty, because I was able to also learn a bit of medicine. I was able to be a functional surgeon. I was able to look at patients in a physician's perspective as well. And of course, I have a very good blend of research, very good blend of endocrinology, and of course, non-operative techniques, minimal access, microwave ablation, ultrasound guided procedures. So the bandworks is quite extensive when you talk about blending medical as well as surgical background. So that's something that interested me. So that's why I put that down. Are you preferring to do emergency work? Do you get a kick out of it? Or are you happy, laid back? You're happy to be chill and do elective work. You're not a night person. You're not interested in having your catecholamine levels higher up. Then probably that's also something that decides your personality and your aptitude. Are you a social person? Do you like interacting with patients? Do you like talking to patients? Then probably endocrine surgery, pediatric surgery, these are more patient require more patient counseling. Limited. Some people don't like really to do extensive counseling. So again, these are things that are based on your personality and your aptitude as to what you want to do. So important thing to remember is we are all of the same breed. The core, we are all surgeons. So the reason why we are here is we already have a baseline aptitude, and that aptitude is common. And each specialty has a little bit of variation in each of these components. Now, the important question is, I don't have a particular aptitude, but I still like a specialty. So should I consider it? This is something that always crosses my mind. This has crossed my mind as well. So that's why I put it down. Now, remember, this is something that you need to really be careful about. Taking up a specialty is like an old-fashioned love story. Okay, and not everything is sweet. It's like a marriage. Not everything is sweet, but it tends to stay with you for a lifetime. So that's how you take these decisions. So these are decisions that are made as stringent as what you would decide when you choose your life partner. And the bottom line is, no one is born a surgeon. Surgeons are made. So if you don't have a particular aptitude, you can always train. Repetitive training can make you better, and surgeons can be made. They are not necessarily born. Now, the next factor is prior exposure or work experience. The MS training days are life defining. They were definitely life defining for me. So a lot of factors, what case variety and volume that you are exposed to. So are you exposed to benign or malignant conditions? So that sometimes you tend to have an inclination to a surgical oncology. Elective versus emergency work, whether you did simple cases in your general surgical training or were you exposed to complex cases. Now remember, case volume, definitely more the cutting that you do is better, but definitely quantity cannot replace quality. So if you do one good thyroidectomy, if a surgeon teaches you how to do one good thyroidectomy with good principles, better than doing 100 shoddy ones. So definitely there is no doubt about that. A very important thing in general surgery training is rotation through different specialties. That is paramount for exposure, and that helps you make up your mind as to what kind of specialty you want to take up. It gives you exposure to the life that an MCH resident lives, the kind of work that they do, kind of complications they face, and you can make these decisions once you get a taste of it yourselves. Now, there's something called an institutional bias. So some institutions do not rotate residents through different units or different super or subspecialties, or a unit may do only particular subtype of cases. So that is a little bit of an issue in our training programs, and this is something we should look at as general surgery curriculum, as general surgery trainees, to make sure that our postgraduates are being exposed to different super specialties or subspecialties. My personal experience in CMC Vellore, I did my surgical training. So we did not have a SGE, we did not have surgical oncology. So I had a great exposure to surgical gastroenterology and surgical oncology. I also had a very good exposure to endocrine, HPB, and vascular, because these were MCH units, but they were within the umbrella of division of surgery. And I did rotate to the other super specialty units like pediatric surgery, thoracic, neurosurgery, urology. And this was my personal experience, and this helped me decide to take up endocrine surgery. Now, mentorship is a very important thing. So a lot of studies, if you look at studies which are looking at why do medical students or why do postgraduates choose a particular surgical specialty, almost 60-70% of responses are in favor of having a very good mentor. So a strong mentor may be either a stalwart who you have never worked with or you've never seen, but you've heard of legends, you've heard of stories of them in your OT, amongst your faculty, amongst the students, or it may be a senior faculty or your head of the department, your own junior faculty who have helped you, who held your hands and taught you how to operate, your own seniors, and of course, sometimes your co-PGs or your co-trainees may also be a mentor for you. Most of these people lead by example. So they are open-minded, they are non-judgmental towards your choices, towards your aptitude and towards your personality. The mentors in the super specialties are good, ideal mentors. Don't show you what is rosy in their specialty, but rather they will show you what are the trials and tribulations that you will have to face when you take up that specialty. And these souls are people who are able to put their specialty before their self. So they are able to empower and encourage the future generation. I was very lucky to have mentors like this during my undergraduate and postgraduate days, and they helped me shape my journey as a super specialist. So another thing to remember is today you might be a mentee, but remember that tomorrow you will be a mentor. So please make sure that you are also a leader by example. These were my mentors. Actually, Professor A.S. Fen was, I've never worked with him. I've only heard tales of the legend. I have had the fortune of being a medical student under Professor Arvindan Nair and later being a junior colleague under him in the corporate. And Professor Paul M.J. and Professor Deepak Abraham held my hands and taught me and led me in endocrine surgery. And that's how I decided to be an endocrine surgeon. And of course, my training unit in KGMC, Dr. Professor Anand Mishra, Dr. Kulranjan Singh, and Dr. Pooja Ramakant, and Professor S.K. Mishra, currently who I work with in Dr. RMLMS. So they are big stalwarts in this field. Another important thing when we talk about factors is work-life balance. Now, I want you to learn this new term, which is work-life integration. So from work-life balance, the focus has now shifted to work-life integration. So from juggling a lot of things during MS training, instead of balancing, now we have to learn to integrate our work, our health, community and community life, home and family. All these things have to be integrated together. A lot of us have family responsibilities at the postgraduate level and at super specialty level. So marriage, if you're unmarried, then when do I get married? Is this the right time? Should I wait to finish MCH? Should I do it before MCH? Big dilemma. People who have children, a lot of responsibilities on your shoulder. I myself had a couple of kids while I took my MCH training. So it is a challenge, but definitely something that you can deal with. Aging parents and siblings that you need to take care of. Now, the kind of work you do, is it emergency intense or on-call intense specialty or not? Very important. Endocrine surgery, thankfully, is not a very on-call intensive specialization. So I can take some time off for my family. So endocrine, plastic surgery, urology, especially if you do endourology, elective pediatric surgery, these are less intense. Neurosurgery, thoracic, oncology, and GI definitely more intense. So might require more time off from family. Again, are you interested in doing long procedures? Do you operate by the calendar or do you operate by the clock? I like to operate by the clock. So short procedures, rapid turnover, patients who are more stable and go out of my ward faster, I'm happier doing them. Again, are you dealing with a sicker patient? All right, are you dealing with a stabler patient subset? That also will decide on what kind of work-life integration and work-life balance you are going to have. So bottom line is prioritize your work, but remember that work is only part of your life, and definitely have a life. If you didn't get to have a life, at least make sure that other people live. So at least pass on to your junior generation, let them have a life. So let's start focusing a little bit on work-life integration when we choose super specialization. Now, very important question that's on everybody's mind, which is vitamin M, which is the money. Very recent article. I don't know whether this is completely authentic, but news of medical professionals taking up Swiggy and Zomato delivery. So money is very important when we talk about specialty and career. So growing inflation, cost of living definitely causes a stress on us. We all have family commitments. We have to have a certain standard of living. And of course, when we retire, we need to have some savings and a retirement fund. So it's very obvious. It's a balance. Higher your workload, longer your operating hours, better the pay, but that comes at the compromise of a little less of work-life integration. So this is something that is a compromise, is a cost that we have to bear. And I am not going to take, I'm not even going to take a shot at comparing specialties because it's oranges versus apples. Very difficult to compare, but as a super specialist, definitely you can look at anywhere between 2 to 4 lakhs as a starting package in any tier 1 city. Again, this is very relative and depends on a lot of things, tier 1, tier 2, so on and so forth. Sky is the limit. So your salary is definitely scalable with experience, with the number of procedures you can do, with the kind of income that you can generate for your hospital. So sky is the limit. You can have a super specialist earning just about 1.5 lakhs, or you can even have 10 lakhs, 12 lakhs. There's really no limit to how much a super specialist can earn. Now, specialization does not necessarily mean better pay. Remember, there are very good, very experienced general surgeons who can speak to their patients very well, who can manage their patients very well, and they have a busier practice and they will any day walk away with more money at the end of the day than a specialist. So this is something you really need to keep in mind. So it's not necessarily, does not translate into better pay. Again, salaried job will have more stable pay, maybe lesser. Locum or private practice will give a little bit more higher pay, but again, it is little kind of taking a chance, may not be steady. Individual choice, but money should not be the only consideration when you decide what kind of specialty you want to do. Remember, beauty fades with time, but your true love will not fade, and that's what I want you to focus on when you choose your specialization. Now, what about future career growth? So again, depends on what kind of setup you're going to be ending up in. So if you're an academic setup, you have a lot of things to consider. Academic positions, what kind of medical college you have opportunities to get a job in. Are you interested in teaching? Are there any teaching posts that are available? What kind of clinical work you will be exposed to? What is the scope for research? What is the scope for publications? Do you have good clinical material to do research and publications? Will you be involved in multiple societies, multiple academic societies? Will you be able to go for conferences? Will you be able to broaden your view? And of course, promotions is something that you really need to consider. So what age you're getting into the academic pipeline and how you're progressing along that the ladder. Definitely, you must, at least in your head, even if you don't become HOD someday, think that you will be heading a department someday, and that will help you contribute better to your specialty and to your department. People in the private practice, it's a question of demand versus supply. So this is something you are going to have to deal with. Now, everything and anything is scalable. So your outpatient practice for the first 3 months will be nil, but slowly it gets better with time, and eventually this is going to translate into better inpatient crowd, and of course a lot more operative procedures and a lot more income. So remember, when you look at specialties, there are some younger specialties, like for example, as Dr. Rajni said, endocrine surgery is a specialty which I beg to differ. It's not something that nobody knows about. It's something that people didn't know about, but in the recent past, I think it's gaining traction. So we are a very young specialty. The advantage is that we are less saturated, we are lesser in number. And of course, we have taken our time to mature. It's been about 20 years we've taken to mature. Now we are still maturing, and hopefully in another 5-10 years time, we will become a lot more mature. Here, the demand is less, but you also have a low supply, lesser number of people. Whereas if you look at established, more popular specialties, like let's say surgical oncology, GI, urology, plastic surgery, these are all quite saturated because they have been there for the last 40, 50, 60 years. They already matured specialties. Here the demand is high, but the supply also is high, and hence you have a stiffer competition. So this is also something. So competition, even when it comes to private practice or when it comes to faculty positions that are vacant in academic institutions. Now the next point is very important, especially if you have a family, is your place of settlement. So are you going to go into a urban practice, or are you going into a rural practice? Now, most of us, I think, I also have to admit I have thought about this. Urban practice definitely gives you the advantage of a lot of amenities, a lot of comfort, especially when it comes to family, so on and so forth. But cities are crowded, competition is higher, and your pay is going to be lesser. So what you would probably be earning, let's say 3.5 lakhs per month at the end of your MCH in a tier 2 city or a smaller town, you probably end up getting 1.5 or maximum 2 at the end of your MCH in a metropolitan city. Rural, definitely remote. Competition is lesser, higher income, you can integrate better with the local community, and you probably will have a more roaring practice than a specialist surgeon that is sitting in a city who has 10 other specialists who are sitting in the same street. So again, metropolitan versus a tier 2, tier 3 city, this is a decision, individual decision that you will have to make considering a lot of other factors. Academic institution versus private practice. Again, institutional practice, I'm sure colleagues in the institutions will agree, you have an assured income, but it's a fixed income. It may not be really that scalable. Stable job, it's got its own perks, it's got its own merits and demerits. You can go for conferences, you've got a lot of accommodation allowances, you've got allowances for conferences, so on and so forth. Private practice, on the other hand, is a variable income, but definitely scalable. Sky is the limit. You can earn. The harder you work, the harder you will earn. So that again comes at the cost of your work-life integration and balance. There is a component of job insecurity, and of course, you'll have to visit multiple places. So it does play have a negative impact on your health and emotional stress aspect. Now, saturation is a big issue that we all have to deal with. So unfortunately, you might find a chai kadda even on the moon. So same way you are going to definitely walk into a specialist down your street wherever you go. It may even happen in a village or a town. So this is something that we all have to deal with, and we have to come to terms with it. The bottom line here is, again, think about your family, think about yourself, your income, your commitments, what kind of monetary setup you want to start. But the focus here again should be on the quality of work. So as long as your quality of work is maintained, is top notch, the remaining part will get taken care of by itself. So don't worry about 10 other urologists or 10 other surgical oncologists in your same locality. If you are going to give good service to your patient, they are going to come back to you and they're going to bring back more. Now, what about the ability to practice independently? This is something that people don't talk about very often when they choose specialties. Now, some specialties may require high-end equipment. You're heavily technology dependent. For example, you use an operating microscope, you use a robot, heavy equipment that you may or may not be able to move around. You need your scopes. So that is something you may or may not be able to practice independently. You might require heavy manpower. Either you have a large operating team, you require intensive anesthesia support, ICU backup, especially people who do transplants, free flaps. All these people do require a large team, good anesthesia backup. So these are factors that might be a hindrance in being able to practice independently. Now, for me as an endocrine and breast surgeon, this was something I found useful. I just need a sterile operating room, few basic instruments, few basic sutures, and my hands, and that's all probably what I need to be able to do my work, at least majority of my bread and butter. Now that said and done, this is a picture of Ida Scudder, who was the founder of CMC Vellore. This was how she started her mobile clinic in the back of a bullock cart. We have reached an era where we actually can even take a robot and move around in a mobile van. So this is something you have to take my words with a bucket load of salt. So this is not black and white. This is something that you have to consider when you want to decide on, can I do my procedures in a smaller hospital independently, or will I have to depend on a larger hospital, larger setup? Do I need more equipment and manpower? So that's something also you need to consider when you choose your specialty. Now, what about competition? This is something that's very important I want to talk about. Competition can arise either from our medical specialties or from our surgical brothers. Medical specialties, issue exists in all specialties. So you have a lot of people doing non-operative modalities, for example, interventional cardiology, radiology, endoscopic procedures. People are placing stents, people are doing bypasses through endoscopic guided medical gastroenterology, minimal access techniques, image guided, for example, microwave, RFA. These are still again predominantly being done by radiologists. And of course, this is a major issue when you compare surgical specialization, how to choose, which is overlap. So now as an endocrine surgeon, I do a thyroid, an ENT surgeon may also be doing a thyroid, a surgical oncology colleague may also be doing a thyroid, a general surgeon will do a thyroid. There are even dental surgeons who do thyroidectomies. So a lot of us are doing the same operation. So specialties may be either field based, like for example, surgical oncology, which deals with all the cancers throughout the body. So they are more field based. And there are specialties which are organ based, like for example, endocrine surgery, which deals with the thyroid, parathyroid, adrenal, neuroendocrine, pancreas, or breast. And mix of both happens in different places. However, the current trend is that we are moving more towards organ based surgery. So remember, you have to realize that you need to live and you need to let live. The organ or the disease does not know and definitely does not care about which specialist is operating. So as long as you are able to give good outcomes to your patient, you're able to sit with your patient, talk to them, convince them to get operated by you, give them good results, they will keep coming back to you and your practice will flourish. So this is not something that overlap is something that will exist, will continue to exist, but that's something we have to live with. And I don't think it's really a major factor in deciding a specialty, but that's something that you need to consider. Now, long-term vision. Where do you see ourselves in 25, 30 years? Definitely scope for innovation. You can look at this. We are talking about AI. We are talking about AI enabled theaters where imaging, everything can be fused. The computer will be able to tell you when you're dissecting in the wrong plane. And rather than your senior rapping you on the knuckles, the computer is going to tell you that you're making a mistake. So scope for innovation, especially in research, both basic science and clinical, exposure to newer surgical techniques, newer technology, newer devices, newer patents. See what excites you. And that's something also you have to consider when you take up a specialty. Are you relevant globally? So can you think outside the box? Think about what can you contribute internationally to your specialty, to the growth of your specialty. Public health perspective, especially since we're talking about rural surgeons, what can you contribute to public health? It may be a tele health system, or it may be going back to the community and operating. So what can you contribute as a specialist to the public health system? You may even become a WHO consultant sometime during your day. So that's something that you need to keep in mind. And of course, your long-term vision depends on, are you going along an academic pathway, or are you going purely on an entrepreneurial pathway? So that's something you have to decide and think about when you consider your long-term plans. So last few slides. So the question here is, so is specialization the be all and end all of what we should be thinking about? My answer and my take on this is definitely no. If you're a good general surgeon, hats off to you. If you want to do specialization, then you're welcome. We welcome you with open arms. Specialization is a choice. It is a choice that is made because you have an area of interest and you want to focus on that particular area of interest. So it is not something that definitely has to be done by all. Of course, you need to consider the other factors. And whatever you do, wherever you go or whoever you become, your first love, that is your basic general surgical principles, should not be forgotten. And this is what will make you a better specialist. So this, I cannot emphasize this enough, that never compromise on what you learned during your general surgical training. During general surgical training, I think focus on being a good general surgeon, keep your mind open, get exposure to all the specialties, and these are things that are going to help you later on being a better specialist. As an endocrine surgeon, if I have a vascular injury, I should be able to repair it. So these are something that will happen only if you focus on your basic surgical training and exposure. Now, very important slide, especially with relation to this conference, is as a specialist, what are you going to give back to the community? So this is something we must, irrespective of whether you're a general surgeon or whether you're a super specialist or a subspecialist, you have to consider this as to what you're giving back to the community. So it's very important thought. Always think about what is the relevance of your specialty to your own community. So how can I take back endocrine surgery or breast surgery, and how can I give back to my own community in terms of preventive health? Now, depends on your specialty. I really can't figure out how neurosurgery, maybe head injury. Yeah, that's something that we can consider. Or peripheral arterial occlusive disease, lifestyle choices. So a lot of ways, innovative ways in which you can think your specialty can be relevant to your own community. This, even if you cannot go directly to the community level, it's important to question yourself whether can you establish a good referral system that percolates right down to the grassroots levels. This is a very important strategy that you can use as a super specialist to give back to the community. A lot of people do this. So this is something, this is a model that I learned out of CMC Vellore, where they have multiple mission hospitals that are spread in the remote corners of the country. And from there, they're able to manage the basic surgical problems through the basic, through the general surgeons and the generalists who are already working, who are quite experienced and quite senior in these remote areas. And when you need a specialist care which requires some dedicated equipment or technology or a dedicated skill set, then they are referred to this tertiary or quaternary surgical center where you can deal with them. And it's also important to have two-way communication. So sometimes you may manage a patient, a specialty patient, and you may want to continue surgical care or follow up at home. That is also something that CMC Vellore has successfully done through its network of mission hospitals. So that's a good model that I think we can look at and we can try to emulate. How can you offer your services to the community? You can do camps, charity, private practice, work harder, make more money. You can give back to the community as charity. You can have partnerships with various NGOs, surveillance or awareness programs. This is something that we do with breast cancer awareness or thyroid cancer awareness. Another important aspect is training. So you can actually impart some of your specialty training as a subspecialty training to the general surgeons. You can offer some fellowship courses or observerships to the general surgeons in your community, where they come and train under you, pick up a few skills that may help manage some of the specialty oriented cases at the community level. So this is something that we need to consider about when we are choosing a specialty. So remember, a surgeon is not a single individual. So there are so many aspects to a surgeon. You can be a completely clinical person, an academic surgeon, a surgeon scientist or a researcher. You can go into administration or a surgeon leader. You can be a surgeon educator, an entrepreneur. You can be a global figure. You can even be a politician. You can be a surgeon policy maker. So you need to figure out what kind. It's not necessarily you have to choose one. So you can be a multifaceted person. You can choose many of these roles, and you can choose what you want to be as a surgeon 10, 15, 20 years down the line. So this is my MS batch of 2015. We 10 of us, out of which 6 of us have become specialists. 4 of us are still general surgeons, doing very well in across the country and abroad as well. These are 5 of my best friends. Each one has taken a different specialty for different reasons, and most of my presentation, I have of course used some literature, but I've also picked each of their brains as to why they chose specialty and what factors they considered when they chose their own specialty. So I would like to conclude. This is a picture actually from Makunda. Very interesting. So I just finished with this small story. I went as a final year postgraduate student as a trainee to Makunda Christian Hospital, which is a remote hospital in Assam. I spent a month there as a general surgeon. I was providing surgical cover. An interesting thing is the surgical services in this hospital are provided by, well, at that point, were provided by Dr. Vijayanand. He's a senior pediatric surgeon, post MCH pediatric surgery, who decided to revive this hospital, settle down in Assam. He's from Tamil Nadu, by the way. He settled down there and he was running the general surgical service along with he used to do ultrasounds as well. At the same time, he used to manage specialty pediatric cases. I have assisted him in a TEF repair, sitting in somewhere in the border of Bangladesh, Mizoram, Assam, and Tripura, with no facilities available, with no CT. So sky is the limit. If you want to go back to the community like what he did, this is a perfect example. So don't think that specialization means you will not go back to the community. So there is definitely scope for everything. And I think with this example, I'll conclude my presentation. I'm sure I've kindled a lot of thoughts in your head. You can always feel free. I can put my email ID and contact number in the chat box. You can feel free to get in touch with me, and we can take this discussion further at a later time. Thank you so much for the opportunity.
Thank you, sir, for such an insightful talk, for providing such a practical, elaborate portrayal of all the factors from choosing a super specialty branch to actually living and practicing the branch. I was quite inquisitive, sir, and I have a question, sir. Looking back
Yes.
at your own career, sir, what is the one thing you wish someone had told you before choosing your super specialty?
Actually, overlap is something that I knew about, but I probably didn't take it. I didn't consider it so seriously. That is something I think maybe I could have explored a bit more. I don't regret it at the moment, but that's something that I think maybe I should have spoken to people a little bit more about. What kind of overlap is. This is something that current generation people definitely are asking. A lot of people who talk to me for career advice, this is the first concern, that everybody's doing thyroid, everybody's doing breast. So I think it doesn't matter. When I was doing my general surgery and I was preparing, I think people were like, people didn't know what endocrine breast surgery was, but today I think that's something that's changed. Other than that, because of my prior work experience, I think more or less I had spoken to enough people. Actually, my intention of joining endocrine surgery after MBBS itself was to see if I liked general surgery in the first place. So I liked general surgery. Then I spent enough time in general surgery. I went to all the specialties. I didn't want to make a very biased decision. So I spent enough time in all the specialties, and then I kind of made up my mind that this was what suited me. Of course, I considered family, income, a lot of other things.
So another quick question: how early in residency should one decide to make up one's mind or frame one's aptitude towards any particular branch?
I really think wait till final year. A lot of people decide when they enter in first year itself. Okay, I want to be like, to be very honest, one of my own batchmates was very clear in first year that he wanted to do plastic surgery, and he ended up being a plastic surgeon. He's very happy with what he does, what he's doing. I'm happy for him. But a lot of us were not very decided. But I think JR3 time is the right time, or maybe even post general surgery SR ship may also be the right time to decide what you want, because I think very early in your career you don't have family, you don't have those commitments. You tend to make decisions based on what you think is best, whereas you don't consider the other factors. I think the other factors also come into play once you're a little bit more older. You have a family, you have monetary commitments. I think those things also definitely play a role. So probably SR ship. Definitely not before JR3. SR ship is probably the right time.
Surely, sir. Thank you, sir. I think we don't have any more queries in the
No
chat
questions
box.
in the chat box and as well as in YouTube. Thank you, Rajini, and
Midun,
thank you, Mithun. That
Dr.
was
Midun Ram.
Thank
fantastic.
you, sir.
Dr.
Yes, sir.
Midun Ram.
I think Shankar has a
He's a
question.
surgical
Okay.
oncologist. Yes, surgical oncologist. He's from. He's a surgical oncologist now, who settled in Assam.
He's actually a pediatric surgeon, sir. There is Dr. Ravi Kannan. Ravi Kannan is
Ravi
Padma
Kannan, yeah.
Bhushan
I
awardee.
was
He's a
talking about
surgical
Ravi.
oncologist. He's also doing. He's also in Assam. He's doing
Ravi
good work.
Kannan, yeah.
This is Dr. Vijay Anand. He's retired now. He's a post MCH pediatric surgery, and he is working. Actually, this is quite remote, very close to the border of Bangladesh. And to be very honest, he has there's just an ultrasound machine, so no access to CT. You have to manage general surgery, you have to manage OG as well. They do have an OGtion, but some complex gynae you'll have to manage, and you have to manage general surgery, of course. So this is something that I
excellent.
found challenging. We operated on a CA stomach without a CT. We had no other option, because it is either you operate or the patient is going to die, because the closest medical facility is 250 kilometers away.
Yeah, northeast. Yeah. Correct. It's a very elaborate and excellent. I think you are a specialist for this. It's very nice.
Thank you so much. Thank you so much, sir.
Not so many 1 in 1,000 also can do what the work you are doing it. I might have met you for decades before. It might have been useful.
Thank you, sir. Thank you, sir. I'm glad.
Thank you.
I was given the opportunity. Thank you. Thanks to Dr. Sabha.
Yeah. Very good, sir. Very nice.
Thank you, sir.
Okay. Thank you, Mithun. Thank you, Rajni. Thank you,
Thank
Dr.
you.
Shankar. Now we go to the next
Thank you, sir.
thing, which is most awaited thing. Dr. Munshi has started sharing his screen. He's an associate professor at SGPGI. And I thank Professor Surendra Kumar Agarwal, sir, and Dr. Munzil Munshi for agreeing to give some insights to rural surgeons about cardiac thoracic vascular surgery aspects. Over to you, Dr. Munshi. Dr. Munshi, you are not audible.
Am I audible now, sir?
Now you are audible.
Okay. My headphones are not working. So, good evening, everyone. Dr. Mithun's session was very enlightening. I wish I could have heard it 10 years back. So, I'll come back to my topic. My slide share is visible to everyone, right? Hello?
Hello, yes?
My slides are visible to everyone?
Slides are visible. Slides are visible.
Okay. So, sorry on behalf of Surendra sir. He had some prior commitments, so he cannot be present here. So today's topic was, as Sabha sir said, CABG, sternotomy, and management of ICD. So I found it little, only CABG. Rather, we'll keep it right like an introduction to coronary revascularization and management of intercostal damage. So first thing, regarding coronary anatomy, there are two main coronary arteries. Left
Dr.
and right.
Munshi, your audio is sometimes not okay. Now audio, there is a problem. Like,
is it better now?
Yeah, now it's okay.
Yeah. So there are two main left and right. Left is again divided into two. Left anterior descending and obtuse marginal. In 15 to 20%, there is one more artery which lies in between the left anterior descending and obtuse marginal, that is ramus intermedius. While right has only one branch, right coronary artery that ends into posterior descending. These two views are taken 90-degree to describe how they divide. So this is the view for. Am I audible? Dr. Sabha, am I audible?
You are audible, sir.
Yeah. So this is the view of right coronary artery, actual anatomic view, surgeon's view, and corresponding CT views. This is the view of left coronary artery and corresponding CT view. So whenever a new trainee joins, I always ask them that why coronary is called coronary. And most of the time they don't have the answer. Now, corona, Krona, is a Greek word, and in Latin it is Corona, corona. They both stand for crown. So actually the coronaries, they surround the left and right ventricle like a crown. That's why they are called as coronary. So this term has come from crown. And actually when we see the LAD and PDA, they unite together at the apex. So as LCX, the OMs and PLV. And they form a structure like a crown. Now, what are the risk factors of coronary artery disease? See, our specialty is equally medical and surgical specialty, the cardiac surgery. So I will be talking about some cardiology topics because they are required. So what are the risk factors for coronary artery disease? It can be divided into two, modifiable and non-modifiable, where modifiables are stress, hypertension, diabetes, smoking, obesity, and hyperlipidemia. While non-modifiable are age, sex, ethnicity, family history, and genetically predisposed metabolic diseases. Now, among modifiable, in current era, stress is running the highest, and it is the one factor that we can control. So how hyperlipidemia affect the coronaries? So as we know that fatty streaks are present even in young age within 10 years, but because of the stress, repeated intimal injury, hyperlipidemia, these fatty streaks get converted into plaque. So that is called as plaque extension. Now, depending upon how much the person is exposed to hyperlipidemia, stress, and intimal injury, it will depend from fatty streak to thin cap, how much time it will take. And generally, in Indian population, it takes 30 to 35 years so that a patient shows symptom by 45, where in European population, this takes around 60 years. And patients who are chronic smokers, alcoholics, and who are high diabetic, this is even exaggerated and it results into 30 years. So this fatty streak turns into thin cap. And after formation of thin cap and repeated intimal injury and fibrosis because of the fibroblast migration, this converts into thick cap. Now, if it turns into thick cap, this is a slow progression of disease. So by 55, patient will be symptomatic, and by 60-65, patient will be severely symptomatic if progression is like that. But if this thin cap ruptures because of some reason, now it all depends upon what stress factor patient is having. If patient is having high diabetes, so the intima is very fragile. The patient is hypertensive, or patient is with stress and having intermittent episode of high hypertension, then there are high chances of this thin cap to rupture. And this presents as a plaque rupture in patient present with acute MI. So from thin cap to plaque rupture is a very acute presentation and we have to act immediately. While thin cap to thick cap, it is slow progression. So once plaque rupture happens, the intima is exposed to the thrombotic agents, and then it causes acute thrombus formation, and patient may present with a acute MI. So this is the whole pathophysiology. So in the phase of plaque expansion, by the phase of plaque expansion, if we can control the factors by lifestyle modification or medication, then we can slow the progress of disease. Now, how we can diagnose coronary artery disease? So we can divide it into three. One is clinical presentation, the 5 main symptoms, out of which chest pain is main. Chest pain, breathing discomfort, and tightness in chest. These are the main presenting symptoms. About investigation, we can divide it into non-invasive and invasive. Amongst invasive, mainstay is ECG. Biomarkers, those are TROPI, CKMB, and 2D echo. So these are easily available investigation modalities. In ECG, there is ST segment, either ST segment depression or elevation. In ischemia, there is ST segment depression, while in infarction, there will be ST segment elevation. In hematology, TROPI or CKMB. So CKMB is, TROPI is more sensitive, while CKMB is more specific. Stress test currently, it is becoming obsolete because in country like India, where we don't have proper facilities available, like places where their stress tests are there, they should have facilities to tackle the acute emergency, because many a times, especially nowadays, we have seen that young people, they go for stress test and they suddenly face an acute MI and they collapse. So that's why stress test is becoming a little bit obsolete nowadays. Other modalities, 2D ecography. So patient, when there is ongoing chest pain, they show acute changes in wall motion abnormality, and that can be detected on 2D echo. while in chronic ischemic heart disease, this become a fixed wall motion abnormality. So in 2D echo, wall motion abnormality and ejection fraction, these are two factors that tells us about the ischemic heart disease chances. Then coronary angiography can be divided into two: CT coronary angio or invasive coronary angio. CT coronary angio is more specific. Like if CT coronary angio shows more plaque, then there are chances of patient having coronary artery disease. While if CT coronary is not showing any plaque, then there is no use of going and doing invasive coronary angio. So by doing CT coronary angio, we can filter patient further, because the invasive coronary angio is having, we can have complications in coronary angio actually. So by doing CT coronary angio, we can further filter the patient and then go for CT coronary angio for definitive management. So this is the coronary angio showing plaque in left anterior descending artery. This is the coronary angio showing plaque in right coronary artery. Now management can be divided into two: conservative or interventional. Conservative mainly concentrates on optimal medical therapy. I will show it into further slides. While interventional, either PCI, percutaneous. Just a minute. Yeah. While active intervention comprises of percutaneous coronary intervention or coronary artery bypass grafting. Now, what is the principle of management of coronary artery disease? So it is based on 5 main factors. First is to reduce the heart rate. By reducing heart rate, we are indirectly reducing the workload. Then left ventricular wall stress. As left ventricle becomes thicker, the perfusion inside the ventricle reduces, the ventricle walls. So we have to reduce the left ventricular wall stress. And reduction in afterload. As blood pressure increases, there is more workload on left ventricle. So these 3 factors determines the workload on left ventricle, that is workload on heart. So controlling these 3 factors mainly known as left ventricular preservation. Other factors are cholesterol control and glycemic control, because these will result, the cholesterol and glycemic control will help controlling progression of plaque. So from streaks to plaque rupture, it all depends upon glycemic control and cholesterol control. Depending on these factors, the medical therapy is given. So it comprises of antiplatelet agent to prevent the clot formation, where aspirin is most widely used. Other blood thinner used are clopidogrel, ticagrelor, or sometimes aspirin and clopidogrel both are used, that is dual antiplatelet. Then renin, angiotensin, aldosterone system. So what renin, angiotensin, aldosterone system does, when the stress on heart increases, it increases the multiplication or thickness of myocardium. As the myocardium becomes thicker, the perfusion to myocardium through microvasculature reduces because of its thickness. So it is demand and supply balance. So as myocardium becomes thick, the supply to myocardium reduces because the coronary flow remains constant. So it all happens because of renin-angiotensin balance. By blocking this system, we prevent the remodeling of heart. And that is what I was talking about, the wall stress, the left ventricular wall stress. So because of RA system, the left ventricular wall becomes thicker, the stress increases in the wall, and that causes, that precludes the ischemia. Then beta blocker mainly causes reduced heart rate. So by reducing heart rate, it reduces the work on the heart. And last but not the least is statin therapy that helps in stabilizing the plaque and prevents plaque rupture. What are other modifiable things we can do is lifestyle modification, regular walk and cardio, sugar management, vitamin. In some of the patients, it shows that vitamin D deficiency predisposes to coronary artery disease. Then other multivitamin supplementation and yoga and meditation. So as you see, in these factors, other than sugar management and vitamin D, rest are to reduce the heart rate. Lifestyle modification, stress management is basically reduces heart rate, reduces stress, reduces blood pressure. Regular walk and cardio will actually help you in utilizing your lipids so that less of lipids are in the blood and your lipid recirculation will increase. Yoga and meditation again will help in controlling the heart rate. So when to intervene? So when to intervene means whether we have to go for either angioplasty or we have to go for CABG. So when there is left main disease more than 50%, LAD disease more than 50%, 2 or 3 vessel involved in the involvement of 2 or 3 vessels or ejection fraction less than 35%, where there is a large area of ischemia with ejection fraction less than 35%, or if patient is symptomatic but the coronary stenosis is less than 50%. Then whether to go for CABG or for angioplasty. So whenever LAD is involved and LAD is involved more than 70%, then we have to go for either CABG or angioplasty. Now, how we decide whether we should go for angioplasty or CABG? So there is something called a syntax score. Syntax score is actually calcium scoring done on the angio, and it is divided 0 to 22 or more than 22. So when this calcium is denser, it is about 22. When calcium is lesser, then it is 0 to 22. So in denser calcium class, it is difficult to do a PCI or percutaneous intervention or angioplasty. So in such patient, CABG is preferred. So whenever LAD is involved or patient with diabetes, we prefer doing a CABG. Or if there's sometimes what happens that there is disease in left main and it is at the junction of LAD and LCX, left circumflex. And in such places, it is difficult to put the stent. So these patients are shortlisted for CABG. When we don't prefer CABG in these cases, when patient is too old, too fragile, or having multiple comorbidities, then we feel that patient won't come out of the surgery, then we prefer doing PCI. So as I said, PCI versus CABG. So what prefers PCI is fragile patient, high comorbidity. When the syntax score is 0 to 22, non-diabetic patient, or there are anatomical difficulties in surgery. Patient post-radiation, patient with bad aorta, bad vessels are preferred for PCI. Where diabetic patient, where patient with low ejection fraction, patient who cannot be given dual antiplatelet for lifelong for stent, or patient who have very dense plaques, syntax score more than 23, are shortlisted for CABG. Now, history of coronary revascularization. So, coronary anastomosis, the vascular anastomosis was first described by Alexis Carrel in 1910, while Arthur Winberg in 1946 did first graft from Lima to left ventricular wall. It was not to the vessel, it was directly to the wall. Then Goetz used first Rima to RCA. Then Rene Favillaro first did RCA interposition graft with SVG. These are just to mention. One of the main inventions in cardiac surgery is by John Gibbon. Between 1934 to 1943, he did multiple experiments to give cardiopulmonary bypass machine. That I will mention at the later stage. So what are the conduits? Conduits are the arteries or veins which are used to put an anastomosis between aorta to the coronary artery, which is non-diseased. So these includes arterial and venous conduits. In arterial, we have internal mammary artery, radial artery, or gastroepiploic artery, while in venous conduits, there is great saphenous vein. So this is internal mammary artery. It runs lateral to the sternum inside the internal thoracic fascia. So when we cut the sternum, we split the sternum and lift it. It is just lateral to the lateral border of the sternum. It runs along the whole length of the sternum till the inferior epigastric artery. So what we do, we put a sternal retractor. I will show it as a demonstrative video. We put a sternal retractor and then we cut open the internal thoracic fascia, retract it down, and then we clip all the branches and we just take down the internal mammary artery, and that is called as skeletonized artery. When we take it with along the internal mammary vein that runs along the internal mammary artery, then it is called as pedicle artery. Basically, skeletonized artery gives us a longer length. Other artery used is radial artery. So we open the skin, we lift the brachioradialis, and below brachioradialis, there's a radial artery. We take it along the length of the vessel. We clip all the branches and then we cut it from the origin and just proximal to the palmar arch, and that is used as a free conduit. So here internal mammary artery is basically used as in situ conduit, means we keep its proximal connection with the subclavian artery and we use its distal connection to give anastomosis to left anterior descending artery. That's why it is known as in situ artery. While radial artery is used as a free graft, where we disconnect it from its origin and use as a free graft. So this is one of the harvested radial artery by skip method. We have made small cuts, and by undermining the dissection below the skin, we have dissected the whole radial artery and then we removed it. And this is the sutured skin after the surgery. Third artery is gastroepiploic artery. Gastroepiploic artery is being taken down from the greater curvature of the stomach by opening the diaphragm, and then it is also used as a in situ artery, where the proximal end is continued from its origin and distal end is anastomosed most commonly to the right coronary artery or posterior descending artery. Third conduit is great saphenous vein, where we dissect the great saphenous vein, we disconnect and use it as a free conduit. We use it by reversing it, means the ankle end goes to aorta while the thigh end goes to the target vessel. This can also be done by skip method. By doing skip method, we reduce the incision and also the scar, and healing also faster. So artery versus vein. It is found that arteries taking arterial conduit is better on long length. Means within 10 years result, if we see, it is same for artery and vein, but beyond 10 years, arteries last longer. The reasons are thicker endothelial layer. It has lesser collagen. It means lesser collagen means there will be lesser hyperplasia, intimal hyperplasia, so that the artery will close later than saphenous vein. Arteries are always exposed to a pressure of 120 by 80, while veins are not exposed to that pressure. Veins are exposed maximum 50 or 60 on standing, and if that pressure sustains, then veins goes into varicosity. So when we put saphenous vein to the aorta, it is exposed to a higher pressure for a longer period. That causes intimal reaction, and that causes hyperplasia and earlier closure of the anastomosis as well as vein. So this is the venous graft over a period of week, month, and year. As we see, because of the intimal hyperplasia, the vein starts closing and even the plaque formation happens faster in vein. When we compare arterial graft versus venous graft, we can see the intimal hyperplasia both in the graft as well as in the conduit vein. This is when it is studied for over a period of 15 years. We can see that there is 40% graft, there is 60% graft failure when we use vein at the end of 15 years, whereas only 20% graft failure when we use artery at the end of 15 years. So this is a demonstrative diagram of cardiopulmonary bypass machine. It's called a CPB machine. So what it does, actually when we operate on heart, if we can keep heart stationary, then the surgery becomes very easy. So in earlier days, in historical period, when they tried operating on heart, they always failed because it was difficult to operate on a beating heart. When it bleeds, patient used to bleed to death. So people tried finding a method by which they can stop the heart, they can bypass the blood to some machine which can act as a heart for time being. So John Gibbon first tried this method, and between 1934 to 1943, he tried to make this CPB machine, which was nearly 1 room big initially, and now it is hardly a fridge size. So what it does, it takes blood from SVC or IVC or from right side of the heart. It passes it through a reservoir. Basically, reservoir is a filter which filters all the impurity of the blood and gives it to a oxygenator chamber. Oxygenator chamber acts as a lung. After oxygenation, blood goes to a roller pump, and then it is being pushed back to the body. So throughout this period, the blood doesn't go to heart is emptied, and we get a clean area to operate. The another thing we use in this method is cardioplasia. Means when there is no blood going to the heart, same time we keep giving intermittent blood circulation to coronaries so that the heart muscles won't go into ischemia. And that thing is called as cardioplasia. So together these things have made many intracardiac procedures possible by paralyzing the heart, by bypassing the blood from the heart, blood coming to the heart to bypass machine, and then reoxygenating and pumping into the body. It keeps the body alive and it keeps the heart empty and field clear so that we can operate on heart. So CABG can be done by 2 methods. One is beating heart and one is on pump. Postplagia means either we can empty the heart and then do the coronary artery bypass grafting, or we can do it on beating heart. So on CPB, we can directly paralyze the heart, handle the heart, open the coronaries, do grafting, and then again get the blood back to the heart and heart pumping. While on beating heart, the tools are different. The main tools in beating heart are octopus, which is the stabilizer, and starfish. Starfish basically helps in positioning of the heart. While starfish is a little costlier, so many institutes use only octopus to stabilize the heart. Now this stabilizer is like a sieving ring, which when is used to sieve the sweater. So it stabilizes that part of the heart so that surgeon can do anastomosis on the coronary. Now sequences in the grafting. Every grafting is considered of various sequences, in which the first thing is choosing the vessel, that is called as target vessel, which is the distal most after the stenos segment. So we consider taking the segment which is not stenosed distally, so that the distal runoff will be good. Once the segment is considered, we do arteriotomy in the segment of the coronary. Post arteriotomy, we put a shunt. Shunt is basically a small lumen pipe that keeps the flow patent. I will show in the video what is shunt. Then once shunt is put, we start sieving conduit to the artery. So this is end to side anastomosis. While when do it as a sequential graft, we do it as a side to side anastomosis. Now, sternotomy is one of the basic steps in opening chest. To reach heart, first we have to handle the sternum. So first I will describe what is anatomy of sternotomy. So when we take incision, mid-sternal incision, we can directly reach to the sternum if we go midline. So what lies on either side of midline is pec major muscle. And we have to take incision between suprasternal notch to xiphoid process. Going deep, we will find nothing but the periosteum of sternum. And when we go down towards the xiphi, we will find linea alba. So we have to go from suprasternal notch till linea alba. Then we have to split linea alba and the interclavicular ligament on each side. We have to pass our finger behind interclavicular ligament and into the linea alba below xiphoid to make space. So this is what lies behind the sternum. So directly behind the sternum lies some thymic fat towards the manubrious sternum, while at the body of the sternum, behind the sternum is directly pericardium, and it is hardly 1 centimeter space, while towards the xiphi there is diaphragm. What are the tools we use is either reverberating saw, oscillating saw, or earlier days people used to use giggly saw. So this is the video, short video of whole CABG. So here we have taken the incision on the sternum from suprasternal notch to xiphoid. We are trying to achieve hemostasis throughout the fat. On your left side is xiphi. This is the suprasternal notch. So we are cutting intraclavicular ligament here. Now I am trying to make a space between interclavicular ligament. That's the space to hitch my saw. Once the space is made, saw is run mid-sternal. Now I have applied retractor to both the ends of sternum. Sternum is retracted. What you will see on the head side is lung. While I'm trying to open the pericardium, here pericardium is open. This is the beating heart. Now I have applied the ionomer retractor to lift up the sternum. Here the sternum is lifted. I am trying to pull down the pleura so that I can reach internal thoracic fascia, because internal mammary artery is just inside the internal thoracic fascia. So this is the whole length of internal mammary artery. Before dividing internal mammary artery, we give heparin. Every anastomosis, when we attempt, we should give heparin. How much it is given? 100 international unit per kg minimum. People also give 100 to 200. Here we have applied the octopus stabilizer on the left anterior descending artery territory. I am trying to score the epicardium to see left anterior descending artery properly. That blue pipe is Mr. Blower we use. It actually blows air to remove the blood from the field. So here scoring is done. Now we have done the arteriotomy, artery is open. This is the shunt we use in coronary surgeries. So basically it is a small fine pipe that keeps the coronary flow, native coronary flow intact. So when we are doing the anastomosis on beating heart, the coronary flow is intact, reduces the intra-op ischemia. So now we are trying to anastomose distal end of left internal mammary artery to left anterior descending. We are approaching towards the end. Before taking the last stitch, we pull out the shunt. So that we can tie off the anastomosis. The shunt is removed and anastomosis is tied. This is how it looks after completion of anastomosis. See, once the suture is tied, all the bleeding stops. The surgeon is trying to tie the anastomosis. We generally use an 8-0 proline for this anastomosis, which is very difficult to see from naked eyes. Similarly, REMA to OM. This we are doing after doing a T graft, that is, REMA is attached to the side of LEMA, where REMA is a free graft and LEMA is in situ graft. I will show you a demonstrative pictogram of that. Here we are doing REMA to OM as a side-to-side graft. So REMA is anastomosed to OM from it to its midpoint. Somewhere at midpoint of REMA, we do a nick and then do a side-to-side anastomosis. So this is called as sequential grafting, where in a sequence we anastomosed more than one vessel from one conduit. You can see REMA is continuing after that anastomosis. So that is the sequential graft. As you can see in the box, LEMA is continued as a in situ graft. So LEMA is in situ, where REMA and part of LEMA are used as a two separate side graft. This is called as pie graft. It looks like a pie. So the proximal one is being given to diagonal, while distal one is given to OM. In coronary artery disease, when we are using artery, we have very limited length of conduit. And we can use bilateral IMA and radial, that's all. While when we use vein, we have comparatively longer length of conduit. So when we are doing total arterial grafting, we have to do all this juggling. So this is Rima to OM. This is part of Lima to diagonal as pie graft. And this is the end of Rima given to PDA as again end to side graft. So 4 grafts from 2 vessels. So this is how it looks at the end. This is Y graft and other as a pie graft, as a side graft, Lima to Lima. So what are the contraindications of OPCAP, that is off pump coronary artery bypass grafting, that is beating heart surgery, when we have difficult targets, when heart is too big, or there is left ventricular dysfunction, or intramyocardial coronary arteries, when the coronary arteries are lying too much deep into the muscle, when we have to cut open the muscle, and it is better to paralyze the heart, that is give cardioplegia, and then put patient on pump. Then small or diffuse disease coronary arteries, then anticipated need of endarterectomy. Endarterectomy is a process when the artery is too hardened, we have to cut open the artery and remove that much part of artery, reconstruct it with either vein or artery, and then do anastomosis. Then patient is hemodynamically unstable, or there is severe pulmonary hypertension, or there are some sternal deformities where it is difficult to manage heart when it is beating, or when we have to do an urgent CABG when patient is not good. So whenever patient is not stable, it is better.
Your voice is not clear.
Whenever patient is not, am I audible now?
Yeah, thank you.
So whenever patient is not stable, it is better to do it on pump, on cardiopulmonary bypass. Whenever anatomy is not favorable, better to do on cardiopulmonary bypass. When the targets are not good or deep-seated inside the muscle, better to do it on pump. So, but when we do beating heart surgery every day, we become master in it, and slowly we can challenge the contraindications. Now, next topic is management of intercostal drainage tube. So for that, we have to consider one condition. I'll start with pneumothorax because it is one of the acute condition where we have to put an ICD on urgent basis. So whenever pneumothorax, patient will have tachypnea, tachycardia, acute presentation on auscultation, one-sided breathing sounds won't be there. There will be tympanic node on percussion. And most, either we can face it during trauma or while putting the neckline. So traumatic and iatrogenic are most common in non-spontaneous. While in spontaneous, it can be present with a large pulmonary bullae, a patient with COPD, or secondary to some other diseases or like interstitial lung disease. So this was just introduction. I won't be going in depth to pneumothorax. I will be rather talking about the ICD. So what is surgical anatomy for ICD insertion? What is the triangle of safety? So in the axilla, lateral to the pec major, anterior to the anterior to the dorsal, latissimus dorsal, and above to fifth intercostal, that corresponds to the nipple. Why fifth intercostal? Because below fifth intercostal diaphragm is very close. Though insertion of diaphragm in anterior axillary line is somewhere around 6 to 7 intercostal space. But as we go below the fifth intercostal, diaphragm comes very close to it. So as I have said, and mid clavicular line, diaphragm is somewhere around 6 intercostal space, while in anterior axillary line it is at 8, mid axillary line it is at 10, and posterior it is at 12. But if we see the three-dimensional structure of diaphragm, below 6 intercostal, it is very much close to the chest wall. So chances of injuring diaphragm is more. That's why we consider fifth intercostal as a safety margin. So what all lies in the chest wall? This is a descriptive X-ray. What we can see is everything lies in the mediastinum. What lies exactly in the right hemithorax is nothing but lungs. So we have to be careful about lung while putting the ICD. Same way here, as we see, there is nothing important lying in the hemithorax. Everything lies in the mediastinum. So what is the safety while putting the ICD? So safety is primary pathology itself. If it is pneumothorax or pleural effusion, both the conditions pushes the lungs away from the chest wall. So that is our main safety. So when patient is having pneumothorax or pleural effusion, you don't worry about the lung, underlying lung below the chest wall. Because of the pneumo or pleural effusion, it is already pushed away. We can be little bold and put our instrument inside the chest. So when we are entering into triangle of safety, how we have to enter? This is the demonstrative diagram of chest wall. We generally go below the intercostal space, lower margin of intercostal space or upper margin of the rib, because the lower margin of the rib contains the main neurovascular bundle. So all the major artery and vein are running below the lower margin of the rib or upper margin of the intercostal space. So that is the place we should not enter while giving the anesthesia. We should consider the upper part of the intercostal space so that we can numb the nerves supplying the same intercostal space. But when we are entering with the instrument, we have to go lower part of the intercostal space. This is the CTS video for demonstration of ICD.
I help orient the patient's head to the right of the screen and her feet to the left. It is always important to identify your landmarks, even in an emergency situation, because you want the tube to go in quickly and into the right place. This time up front is well spent and saves the time and the effort of a poorly placed tube. We start by identifying the tip of the scapula. This can be accomplished by pushing down on the shoulder to gently move the scapula against your finger. Mark that spot. Next, feel for the anterior superior iliac spine. Between these 2 points is going to help you to identify your mid-axillary line. It is ideal to place chest tubes in front of this line for patient comfort so that they're not laying on the chest tube. There are, of course, some special circumstances in which an alternate location will be required, in particular if you're aiming for a loculation, and sometimes you are limited by casting or hardware. Next, identify the nipple and the inframammary or pectoral crease. This is the line in which you're going to be placing your chest tube. Next, identify the 12th rib. This is going to help you approximate the lie of the diaphragm. Remember that the dome of the diaphragm can be as high as T4 or even more elevated in certain disease processes. These can include diaphragmatic paralysis, diaphragmatic eventration. It is essential to know your patient's history and to review your radiology very carefully before beginning your procedure. Sometimes having the chest X-ray on the screen in the room is also very helpful. Lateral to the nipple is a safe place in most patients for chest tube insertion. Before even beginning to prep or drape your patient, plan your incision. It can be very helpful to use a marking pen to mark out your incision before you even begin to make sure that you have a very firm idea of where you want to place your tube. When draping, always make sure to keep your landmarks in view so that you can plan your incision or change accordingly. Always make sure that you have an adequately sized incision. Here that you can see that we are planning an incision that has adequate room for us to introduce both our finger and the chest tube to allow us to help direct the tube and ensure accurate placement. Note that our incision is going to be approximately 2.5 centimeters, maybe a little bit larger in some patients, to allow careful insertion of the chest tube. The timeout is essential. Verify your patient. Straight is always a great technique. Please note the proper way to hold the scalpel. This allows for a controlled incision. For patients who are intubated and asleep, you have the benefit of general anesthesia. For awake patients on the floor, chest tube insertion can be performed in a comfortable manner without the use of sedation if local is performed properly. Skin must be anesthetized and allow adequate time for the medication to take effect. As dissection is carried down to the chest wall, each layer should be anesthetized, followed by the pleura again, allowing time after each step for the local to take effect. Have all 30 mLs drawn up ahead of time and ready to use. In particularly deep patients, a Kelly clamp can be used to help identify the path the needle needs to follow. Our incision is created. Blunt dissection is carried down to the chest wall. A finger can be used to help identify the top part of the rib. Remember that the intercostal artery, vein, and nerve run along the underside of the rib, and injury to these vessels can result in a significant amount of bleeding. The chest should be entered bluntly with a hemostat or curved Kelly clamp, or even your finger. Brace your dominant hand with your second hand to avoid advancing the clamp too far into the chest, risking injury to the lung or even the heart on the left side. Dilate the tract, starting at the level of the pleura, backing into the muscle, the sub-Q, all the way up to the level of the skin. Perform a finger sweep to confirm that there are no adhesions. Insert the chest tube using a Kelly clamp or your finger to guide the tube into the desired location. Apical for air, posteriorly for fluid, or into the specifically desired collection. In an awake patient, the finger can be very helpful in directing the chest tube away from the fissure and keeping it along the chest wall. Securing the tube is very important, just as important as placing the tube. We like to secure our tubes with a large silk suture. It is important to take large bites of the skin, as you can see us doing, so that the tube will not be pulled and the suture will not be pulled through the skin. Tie many knots. Once you have a little bit of a trail, go around this chest tube several times. Cinch down to create a small waist on the chest tube, not enough that you're going to impede drainage, but enough to hold the chest tube securely. Time to re-secure the tube, chest tube to an inadequately secured tube. This is a second suture to close the extrusion of fluid or the introduction of air by taking time.
So, after putting chest tube, it is very important to see the column movement. When patient breathes in, the column should be pulled towards the chest, and when patient coughs or breathes out, the column should be moving towards the ICD drainage system or ICD bag. So as we can see, this is properly placed chest tube. And whenever patient breathes in, there will be movement in the column. That means it is directly into the interpleural space, the place where we want it. So if this movement is not there, we better be putting the drain again or check the place properly. So what are the types of intercostal drainage system? Now, when we put an ICD, the other end of the tube should always be underwater, because if we keep it open, When patient breathes in, there will be negative intrapleural pressure and all the air will be sucked in. So it will cause more of pneumothorax than relieving it. It may become as an open pneumothorax. So the another end should always be underwater, as it is shown in this video. So here we can see when patient breathes in, the water is pulled inside, but air is not going because it is underwater. So what are the types of intercostal drainage? One we get as a commercial Romovac. It is a single tube inside the water level, and the open end of the another tube is basically to apply suction. So when we apply suction, this suction pressure directly gets conducted into intrapleural cavity, and if something is collected inside, it will come out. Another thing, we use it to a collapsed lung. When the lung is collapsed, putting a negative suction helps in expansion of the lung with the active spirometry or active chest physiotherapy. When it is commercially not available, we can use two bottle system, where the place where the ICD is connected is open to an open system of a bottle, as it is shown in left diagram, and from there an intercostal another bottle is connected, and here the tube is underwater, and the open end of this bottle is to the atmosphere. Now when patient breathes in, the air between these two bottles is utilized to go in, while extra air doesn't go in the intrapleural space, which is guarded by underwater seal. So when patient coughs or breathes in with pressure, the air which is in right-sided bottle, that can only transfer. When we apply negative pressure to the left-sided bottle, to the open end to the air, then it will suck out all the air from the right-sided bottle. But air cannot go into the right-sided bottle from the left as it is underwater. So simplifying this mechanism, a commercial system is made. It is called as plurivac. So as we can see on the right side, the blood can come to the ICD water, while air transfers from the above and gets sucked from the suction system on the left side. But there is no way air can enter into the ICD tube and enter into intrapleural space. So this commercial system is plurivac. It is little costly. It costs somewhere around 2,000 rupees. And it cannot be reused. Once you reach that 2,500 ml level, you will have to change it. Now here the negative air pressure can be guarded. It comes at the level of 10, 20 and up to minus 150. Once we put a switch to 10 or 20, it will let that much negative pressure, not more than that, irrespective of how much pressure you apply from wall suction. This is my department from SGPGI. So whatever I could achieve by now, or whatever I'm today, is all because of these people. And I'm really thankful to Dr. Sabaratnam for giving me this opportunity. Over to you, Dr. Sabaratnam.
Thank you, Dr. Munshi. I have no words. Greatly indebted for to you and Professor SK sir and the entire team, including Shantanu Pandey sir and the entire team. And you made it very lucid for everyone. And 1 hour 20 minutes
I'm
to
actually
speak.
this whole process is little difficult. This cardiac surgery to explain
Yes.
in one thing.
Actually, yeah, I understand, but the problem is to share the knowledge with the have-nots. Like many people will not even see what is CAPG in their MS general surgery training, and how to put a chest tube. The thing, even how to tie a knot, and all practical points you covered. And we are thankful. And any questions are there? I don't think it's already 9 and YouTube people are watching, but there will be less of interaction. But thank you once again, and we uh, we consider this as a successful conference. More than 600 PGs have seen the videos daily, and they have benefited in the YouTube. So I we will not have a formal valedictory function, but I say that it's gone on well with the students. And thank you all faculty, without whom this is not possible. And 5 days, over 5 days, 20 hours we did. And thank you once again, and thank you all till we meet next time. Bye.
Bharatnam sir, can I make a request?
Yeah.
Those who are interested in cardiac surgery and who would like to know how it all happens, they are invited to SGPGI and Department of APS to come and see that how we do it and how we handle the patient, how the surgeries happen. Because seeing it from outside, it looks very complex. So anyone who wants to come and see in SGPGI, they are welcome. They can contact Dr. Sabaratnam, and then we will see.
No, they can contact me. We will redirect to you. Like for example, urology, 2 people have wanted to come after day before yesterday's thing. So we have sent. And like for example, plastic surgery, after their presentation, 2-3 students want. So actually, whenever they are willing, see, actually that is, we are only facilitating. And as you rightly pointed out, they should come and see also the specialty and see how much good work is being done. And it's a real boom to work in such institutes. So thank you, Dr. Munshi, for that valuable point also. And thank you, Dr. Shankar. Dr. Shankar has been like pillar of strength for us every day, asking some questions. Dr. Mithun Ram for his wonderful talk. Dr. Prashant, everyone. Thank you very much. Bye.